welcome you all to the third day of the fifth lung cancer year-end review 2021, and we hope that you have had an enriching experience over the past 2 days, and we wish to continue it forward today as well. We all know that advancing age is an increasing risk factor for malignancy, and it is expected by the year 2050, India will have more than 300 million people above the age of 60 years. This will constitute around 20% of the total India's population. With this, we can also expect an increase in the prevalence of non-communicable diseases, which includes cancers. Older adults are a special group of people, and along with malignancies, they will have other comorbidities, multiple medications for the same, and cognitive decline. So basically, there is decline in both physical as well as cognitive reserve, which makes treating cancer a challenge in these population. I see geriatric oncology as a rapidly growing field which can address these issues and holistically care not only for the patients but also for the caregivers. I'm really excited. I'm looking forward to all the talks and the panel discussion which addresses a range of topics including informal caregivers, technology in geriatric oncology, the newer therapies, immunotherapies in older adults, as well as the newer updates in the field of geriatric oncology. With this, let's begin the geriatric oncology workshop. I would like to welcome the chairpersons, Dr. Kruma Prabhas, Professor, and the head of the Department of Medical Oncology, Tata Memorial Hospital, Mumbai, and Dr. Sapna Nanjia, Senior Consultant, Department of Radiation Oncology, Apollo Proton Cancer Center, Chennai. Thank you.
So, good morning, everyone. That's from India, and I'm sure these good morning and good evening will be different from different part of the world. And we'll start without wasting time. We'll start with the first session, and we can have our first speaker for the day. And first speaker for the day we have by Dr. Sindhuja Kadambi, and she'll be talking on informal caregivers of older adults with cancer. And this will be a topic which will be fairly new to many people, and one of the aspect which many times, or I'll say frequently, we miss in the clinic. So we may go ahead with the presentation, please.
I'm going to share my screen. Is everyone able to see it and hear me okay?
Yes, ma'am.
Okay. Thank you for that introduction. Good morning, everyone. My name is Sindhu Kadambi. I'm a geriatric oncologist specializing in genitourinary cancers at the University of Rochester in Rochester, New York, in the USA. Thank you, Dr. Naranha, for giving me this opportunity to be a part of this workshop and share with you this talk on my research focus, which is informal caregivers of older adults with cancer. I'd like to start with a clinical vignette. I'd like for you to meet Revati. She's a 74-year-old woman with a medical history of hypertension, diabetes, and arthritis. She lives with her husband, Govind, who's 77 years old, and was recently diagnosed with advanced prostate cancer. She's a sole care provider for her husband. They have 3 children, one of whom lives locally, but they have their own lives and are busy. So in addition to being responsible for all of her household duties, she spends about 30 hours a week providing care to Govind. She accompanies him to all of his appointments. She helps him manage his medications, communicates with his physicians, is an integral part of his health care. Overall, she feels satisfied knowing she's providing Govind with good care, but she also notes that her responsibilities have increased, while her social circle and activities have decreased. This is a quote from a qualitative study of caregivers of older adults with cancer that was recently presented by Yang et al. At the most recent SIOG conference that really applies to her. She'd say, he was very active before, and right now it's even difficult for him to walk a few houses out. I don't know how much care he'll need in the future or if we'll need to move, so there's a lot of uncertainty and just frustration. And she notes that in addition, she's not taking care of her own health. as she should. She's having to reschedule her own health appointments, and it's really taken a toll. And she's been experiencing some lows. And I think you'd all agree that this is not an uncommon scenario. I'm sure you've seen it with your own patients and their caregivers. In fact, cancer caregivers are a massive population. In the United States, 2.8 million people provide care to a person with cancer, and they provide approximately 63% of the home care to our older adults with cancer. And with the increase in the aging population of patients with cancer and improvement in oncology treatments, the number of informal caregivers is only expected to exponentially increase. So who is an informal caregiver? They're really family or friends who provide unpaid care to our patients outside the clinical setting. And I said with a more of a push for our patients to be cared for at home, we're increasingly dependent on our caregivers to provide our patients with day-to-day care. And when we look at our caregivers who are taking care of patients with cancer compared to non-cancer caregivers, we see that cancer caregivers experience a greater burden from caregiving as shown here, and that they provide much more assistance when it comes to things like activities of daily living, such as toileting and bathing, as well as instrumental activities of daily living, such as housework, transportation, and managing finances. And this is especially true for caregivers of older adults with cancer. Older patients with cancer have high prevalence of age-related conditions, such as comorbidities and geriatric impairments. In a large multi-center study of patients age 70 and older with advanced cancer, Dr. Mohili et al. Found that 86% of patients had at least 3 or more geriatric assessment domain impairments. In fact, 94% had impaired physical function and 35% had cognitive impairment. As a result, older patients with cancer have increased needs of assistance from caregivers. And the caregivers provide older patients with cancer with an average of 32 hours of care per week. They help our patients in a variety of ways, including self-care, again, such as bathing and toileting and household tasks. We ask them to perform nursing care without training, such as managing symptoms, treatment-related adverse effects, and catheter and ostomy care. And they not only provide emotional support, but really act as advocates communicating with their healthcare providers. They're involved in all aspects of healthcare decision-making as it pertains to the patient and assist even with end-of-life decisions. And what we found in a cross-sectional study of 414 caregivers of older adults with cancer is that caregivers themselves are older. Found that 65% of caregivers were over the age of 65. Most were cohabiting partners or spouses, and a significant number, almost 40%, reported comorbidities. And while caregivers do report positive aspects of caregiving, such as deeper relationship with patients and an improved sense of self-worth, caregiving can be difficult for our older caregivers. There can be strains in marital and family relationships, and due to age, as they're already experiencing limited finances, there can be decreased economic security. They experience a decrease in their social network and are more likely to be caring without unpaid help. What we also know is that in vulnerable caregivers or those with prior health conditions, a significant number, found as 32% of vulnerable caregivers, felt their health had suffered as a result of providing care for a patient. They can experience fatigue from inadequate time to rest because they're caring for someone. They're less likely to engage in healthy lifestyle behaviors such as exercise, and more likely to engage in negative behaviors such as increased alcohol use. They're also less likely to be proactive about their own health. And studies have shown that caregiving can result in weight gain, increased cardiovascular disease, and poor immune functioning. And caregivers of our older adults can experience, as a result, significant physical and psychological hardships because of caregiving. Lee Kehoe et al. From our group found that among caregivers of patients aged 70 and older with advanced cancer, 39% of caregivers reported distress, 21% reported anxiety, and 15% reported depression. And our group showed that in older patients, GA impairments can predict poor outcomes in caregivers. And what we've shown is that an increased number of patient geriatric assessment domain impairments leads to increased caregiver depression and lower physical health and quality of life. And the impact of caregiver burden can be significant and can impact not only caregiver health, as I've also already shown, but can result in morbidity and mortality. In a study of 392 spousal caregivers, 56% reported caregiver strain, and these caregivers had 63% increased risk of 4-year mortality, even when controlling for demographics and health status. And caregiver burden, in turn, can lead to poor care for our patients, including increased patient distress, increased risk of hospitalization, and the use of aggressive and unnecessary treatments at the end of life, all leading to increased all-cause mortality in our patients. So although it's not commonly integrated, caregiver burden assessment is important, but it's not routinely done in our healthcare delivery systems. I've shown you an example of a survey that can be used. It's called the Zarit Burden Interview Survey, which has been validated in advanced conditions, including cancer. Its short form includes 12 questions that I've shown here. For example, ask questions such as, do you feel stressed between caring for your relative and trying to meet other responsibilities for your family and work? And really, the recommendations are that this caregiver burden should be measured at any point in contact with the healthcare system of the patient and the caregiver, but especially at the first diagnosed with cancer and anytime the patient and caregiver presents to the ED or a major emergency department or a major transition is planned. But this is really rarely used in clinical practice, and there's no guidance on how to best manage caregiver burden once it's identified. So how do we identify caregivers at risk for distress and intervene or provide support sooner? This is a conceptual framework that summarizes the contributors to caregiver distress. There are patient and caregiver traits, as well as intensity of care and available support, all play a role. Patient characteristics that lead to greater anxiety and depression in caregivers include poor Eastern Cooperative Oncology Group, or ECOG performance status, solid tumors as opposed to hematologic malignancies, and patients requiring, as I've already alluded to, assistance with ADLs and IADLs, and those having greater symptom burden and emotional distress. Caregiver characteristics, on the other hand, include psychological symptoms, for increased psychological symptoms were younger age, being a spouse, poor health status in the caregiver, lower social support, and having poor coping skills. So really selecting interventions that includes a needs assessment and that can target the priority areas would be particularly effective approach, especially given that both the patient and caregiver's needs are so varied. We recently evaluated the role of caregiver mastery and depression in caregivers of older adults with cancer. We're really interested. Environmental mastery is an individual sense of control over and effectiveness in managing life situations. It reflects a caregiver's ability to cope, adjust, and adapt to problems. It can be assessed with a validated survey such as the REEF Environmental Mastery Subscale, and we hypothesize that higher mastery may attenuate the negative effects of caregiving stress. So to evaluate the effects of mastery on depression in caregivers of older adults with cancer with functional impairments, we performed a secondary analysis of data from a large randomized study conducted by the University of Rochester's National Cancer Institute's Community Oncology Program. The COACH study, conducted by Dr. Supriya Mohili, enrolled older adults with advanced cancer who had at least one GA impairment and their caregivers, and sought to improve communication between patients, caregivers, and oncologists about age-related concerns. Patient functional status was assessed by patient-reported impairments in ADLs or IADLs, and caregivers were asked to complete the REEF Mastery Subscale, which is shown here, and the PHQ-2 to assess depression. And the subscale consists of 7 individualized items. Each is scored from 1 to 5 with a total score of between 7 to 35. And higher numbers indicate having a sense of mastery or competence in managing the environment and external activities, including caregiving responsibilities. What we found was that 61% of the patients in this population had impaired function, 15% of caregivers reported depression, and the mean caregiver mastery score was 27.6, with a range between 7 and 35. We found that caregiver mastery moderated the association between patient functional impairment and caregiver depression. So in other words, for each unit increase in the caregiver mastery score, odds of depression decreased by 37% in caregivers of patients with functional impairment compared to 21% in caregivers of patients without functional impairment. So we found that caregiver mastery can attenuate the association between patient functional impairment and increased caregiver depression, suggesting that interventions to increase caregiver mastery may help caregiver emotional health. But there really are a wide range of interventions, such as cognitive, behavioral, complementary or alternative medicine, family or couples, interpersonal, problem solving, or psychoeducational supported therapies that are available for caregivers as possible interventions. They've been shown in a wide range of studies to improve problem solving and caregiving skills, in addition to reducing burden and decreasing depression and anxiety in caregivers. But there's wide variability among these studies, making it difficult to compare between them. And there really is a need for rigorous studies that are adequately powered to examine validated and reliable caregiver outcome measures. In addition, these interventions have mainly been tested in older adults with dementia and in cancer caregivers. There really have been no interventions that have been tested in caregivers of older adults with cancer. And so interventions that are provided to both patients and caregivers would be particularly beneficial in this population. So because our group has shown that geriatric assessment impairments can predict poor outcomes in caregivers, and we know that caregivers of older adults themselves are older with comorbidities and likely also have age-related conditions, we're currently conducting a study to utilize the geriatric assessment in both patients and caregivers to formally assess age-related conditions and the health status of both the caregiver and the patient, and really identify whether the caregiver is able to provide care. This is a pilot study that I'm conducting, with the first phase being to determine whether it's feasible to conduct the geriatric assessment in caregivers in addition to the patients. And I'm planning on enrolling patients over the age of 65 with advanced cancer and their caregivers who are also over the age of 65. We're going to be doing longitudinal assessments with the GA in caregivers over an 8-week period while they're just adjusting to caring for someone with a new diagnosis of cancer. We're also planning to engage key stakeholders, including our community advisory board of older adults with cancer and their caregivers, and geriatric oncology experts from the Cancer and Aging Research Group, as well as primary care providers. Using their input, we're hoping to identify high-impact supportive care interventions, as well as procedures to implement these interventions. Our ultimate goal is to develop and pilot a supportive care management algorithm where we can identify caregivers at risk for burden and provide supportive care recommendations. We just received regulatory approval for the study, and we're actively in the process of enrolling both patients and caregivers. So in summary, as a take-home messages, I hope I've conveyed that as a population ages, there will be more informal caregivers of older adults with cancer. And older adults with cancer have unique needs as do caregivers. And the caregiver should really be treated as an invisible patient there with us in clinic. And that because they can experience significant burden as well from the patient having a diagnosis of cancer and from caregiving, and they really should be screened. But future studies are required to test and implement these interventions in caregivers of older adults with cancer. And we're hoping to be able to do that. Thank you. And I'll just end. This is our University of Rochester's Geriatric Oncology Research Group program. Without whose support, and none of this would be possible. Thank you.
Thank you very much, Dr. Sindhuja. That was really an insightful and very thought-provoking talk, especially in the reference of our, in Asian societies. I think caregivers are often taken for granted, and all the more reason for us in India to be, thinking about the caregivers. So thank you so much for your talk. Are there any questions?
Yeah, ma'am. Sindhuja, ma'am, I have a question for you. So definitely, ma'am, you have touched upon a very important topic, which is overlooked. Most of the time we attend conferences and workshops, we are discussing about a caregiver. So this is really, really important for us. So ma'am, what do you suggest that should be done practically to provide more and more support to caregivers? What we should do on a practical level or practical basis in our own society, in our own patients, caregivers, that we can do to improve caregiver support?
Thank you for that question. I think an important aspect to this is that I think between societies there are going to be different needs of caregivers, right? And I think in different cultural systems, that caregivers and that burden can be different. The expectations can be different, how they experience can be different. So I think it's really important to understand what the caregiver needs are. And I don't think that we've quite even done that yet. We don't really know what our caregiver population really looks like and what their needs are. So I think that's the first aspect of it. From a clinical perspective, I think really just thinking about, we always think about the caregiver as, we kind of operationalize the caregiver, right? We only look at them as this person who's helping the patient, as opposed to a person who's also experiencing this diagnosis and treatment. So I think coming from that perspective in clinic with you, really asking the questions of the amount of care that they're providing, is there additional support that they're looking for? Just asking those questions in itself, I think, can be really helpful. And I do find that by asking that, I do get a social worker. That's one of the supports that we have, is having a social worker in our clinics to be able to reach out then to see if there's aid services or, home nursing that can be provided as additional support. But those are some of the basic tools that we have right now to be able to support both our patient and our caregivers.
Would forming a support group where similar caregivers are given a chance to interact with each other and help each other, would that help?
Yeah, I think that there have been studies, not necessarily in our population, but in other caregiver studies, where they have talked about support groups being quite helpful. I think they do find that it helps in terms of understanding educational opportunities, as well as reducing some of the anxiety and mood symptoms that can accompany from caregiving. I think for older caregivers, because they also have that comorbidities and age-related conditions, that can be really impactful. And so I think that just support groups alone can play some role, but I think we need to offer them real substantial support as well.
Thank you.
I can't tell if I'm freezing up or if it's, so hopefully you can hear me.
No, we can hear you well. We can hear you well. At least I can, Dr. Sindhuja.
We can as well here in the venue.
Yeah. So, are there any other comments? Dr. Vanitha, would you like to come in and say something?
Yes, I have a couple of questions. Thank you so much. That was a really excellent and insightful talk, Dr. Kadambi. So, a couple of questions for you. We usually do the geriatric assessment right at the start of their cancer journey. What do you suggest is the optimal time to assess caregiver burden? So we assess everything at one go, but I would imagine the caregiver burden would be the least at the start and perhaps build up as they go along. But so your comments on that?
Yeah, I agree with you. So I think that's part of the pilot that we're doing. So we're going to be doing the geriatric assessment for both a patient and a caregiver within 4 weeks of a new diagnosis, and then repeating the assessment 8 weeks after to determine what's changing with the caregiver's health status as well as their caregiver burden. So we'll be doing some qualitative interviews as well as using some surveys to assess burden. I think I'm hoping that'll give us some information. But I agree with you. And I do think that assessing at multiple different time points, knowing where, because even just that initial shock of the diagnosis can be a lot, especially for, the caregiver who may have their own health issues or, difficulties from the beginning. So they may have some burden even from the get-go. So I think even the baseline, just understanding where they are and then following up and repeating would be important.
So, and another question that we face, perhaps this is a more ethnically specific problem. So many times our patients are not accompanied by their primary caregiver. So they come with their grandchild or their child who's actually not doing the caregiving at home, which is the spouse. So and I think we try that when the patient registers for the geriatric clinic, we give out the forms, but by and large, they don't get filled out. So, and they get filled out when they come to the clinic, and that's not really reflecting the caregiver burden. Do you have any tips for us how to,
I was just curious, with COVID, are you doing more telemedicine, or have you been able to do more virtual visits at home?
So no, not yet. We have been trying that. I haven't reached that level of confidence yet. I think perhaps function and falls is the most, I find that the most difficult to assess as a teleconsult. So there have been many requests. I totally agree with you. And we have been talking in our group that we need to start this, but I haven't, I was talking to Dr. Melissa Low, and she was giving me tips as to how to do this electronically, but I haven't yet started.
I think it's so important to have them be present, because you can get such different stories, right, from the patient and from the caregiver, and the way that they're experiencing, a lot of times the patient doesn't always know what their deficits are in the way that the caregiver might, right? So I've had so many times where the patient says, "Oh, I'm doing fine. I'm doing independent. I'm doing everything." And the caregiver is sitting next to them, just shaking their head saying, "No, he's forgetting things. He has been falling." It's important for them to be there. And I'm not quite sure how else to bring them into the conversation if they're not coming into the clinic. Because one of the things with the study is also the caregiver is not your patient, right? So there some, so in terms of who's responsible as a physician for the caregiver, that brings up some issues. So it's not as if you can call the caregiver afterwards. I mean, you potentially could have permission from the patient to call and say, "Can I speak to the person who's at home with you?" Just to get some sense of how things are going. But I don't know if there would be some barriers to being able to do that after the visit.
I would also, like to say something about it's a bit politically incorrect. Sometimes, we see a spectrum where patients may be very guilty about having fallen ill and having, being a burden. But on the other hand, sometimes there is a lack of sensitivity that the cancer diagnosis also impacts the caregiver enormously. Mm-hmm. And I just wondered whether, you have encountered that, or have the others encountered it, and how one deals with that, because, sometimes there can be a lack of sensitivity towards the needs of the caregiver.
Mm-hmm. Yeah, I think that can be a challenge. And I think that being the caregiver, well, if they do come to clinic with you as that invisible patient, can be helpful. And I do say, if you're both going through this together, it's something that you're both experiencing, and it's difficult on different levels for both of you. So how can I help? And I do think that takes, I think that helps also to let them tell me any ways that I can support both of them. But I think maybe doing those assessments where you're for caregiver burden might be one way also to really understand that piece a little bit more and let the caregiver know that you are also thinking about them.
Yes, I think that the acknowledgement of what the caregiver is doing is so important. Very right.
But if they're not coming into clinic, that can be such a challenge. It has been hard with COVID when we had lockdowns where they weren't able to be in the room. But I put them on the phone. I say, "Do you want to call them?" And then just have them join on the phone. So they can be a part of the visit.
Sure.
So, ma'am, caregiving is mostly a culture-based approach. As in India, we see initially the relatives are mostly involved. And with time now, though the scene is changing, the people are getting hired for caregiving too. But we should have a program, basically a counseling session for these caregivers too, that how to go for. As we see in our patients, what we happen, initially when they get diagnosed with cancer, there are many relatives and many person comes as a caregiver. But with time, in due course, within 6 months, we hardly find anybody accompanying the patient with time. So this approach has to be with counseling of the basically relatives and the caregivers have to be started in the initial stage only, so that the people can be get staggered over the period of 6 months or a year for giving the care to the patients, and not all the caregivers coming initially in the first month only, and thereafter the patient get left alone. So we have to have a protocol for this.
No, that seems really important. It seems like there needs to be an educational component there when you're doing these assessments, right? To set expectations and ask that. And it sounds like they need to be a little bit more aware of what their role should be moving forward.
My experience has actually been, it's varied. So we have certain communities in India where I feel, this is my assessment over the years, is that, the this caregiving has also been thought through. And so there's actually, like a relay. So there'll be a big family and there'll be people who will have planned, who will be with the patient. That kind of family support is actually just enormous. So when it all comes on one person, I think it's very difficult. But when the whole family pitches in and does it in a very organized sort of way, and I've seen that happen with, there are certain communities where what we call the joint family system is very, very, still solid. And then, this has been thought through. So according to everyone's work schedule, duties are assigned. So that's really very nice. I think that's where, so that's, again, as we said, it's cultural. A lot of the caregiving is considered, I should say, it's taken for granted that, of course, it'll be the family, immediate family that'll be done. I don't think there is even an acknowledgement very often of, say, a spouse or a child who may be, or a parent also actually, who might be doing caregiving duties, not for the geriatric population, but patients in general. But on the other hand, I find that there are, especially in joint families, there is a lot of resilience and people kind of come together for this.
That's great. And I think, there are definitely studies showing the importance of social support in general, right? And we see that in our clinics, the patients who have better support tend to do better, right? Cancer outcomes are better, and emotional health, physical health seem to be better when they're well supported.
And also seeking out care if required, counseling and care if required. So we have one more question, and I think this will be the last question before we close this session. Is caregiver burden different with different cancer sites or advanced disease?
It appears to be. There are certain cancer types. It seemed as though solid tumors, for example, had caregivers of patients with solid tumors, for example, GI tumors, seem to experience more burden. That may be because there's, there are GI cancers, there may be ostomies involved, feeding can be difficult, things like that can make an impact. And advanced disease in itself carries a different burden in that, as opposed to localized disease, advanced disease, I think, also carries a sort of existential crisis, right, of like having a disease that may be incurable. And it may require more prolonged or more intense period of care. So the burden in that is different.
Yeah. So thank you very much, Dr. Kadambi, for a wonderful session.
Thank you so much for having me.
So we move on to our next session, and the talk is on update on the key studies in geriatric oncology in 2021. And I would like to introduce our speaker. Our speaker is going to be Professor Ravindran Dhaneshwaran, who's the Deputy Chair and Senior Consultant in Division of Medical Oncology in the National Cancer Center, Singapore, and also Associate Professor in Duke NUS Medical School, Singapore, also President of SIOG, and it's indeed a pleasure to have you here, Professor Ravindran.
Thank you, Dr. Nagia, and also thank you to Dr. Norona and the team at this review course for inviting me to speak today. It's truly a pleasure to come back again and share with you some of the geriatric oncology updates over this past year. Let me put it on full screen. Just keep it a bit. If you can hear me clearly. So today, thank you. So today I'm going to talk to you about some geriatric oncology updates. Some are abstracts, publications. It's not comprehensive, but I have decided to focus on certain key studies which I feel will be beneficial for everyone to be aware of and learn from. These are my disclosures. So I've broken it down into some abstracts from big meetings like ASCO, important SIOP publications, JGO publications, and others. And I will summarize right at the end. So I'll start with ASCO oral presentations. So this was one of those presented at ASCO this year by the Notch team. Basically, This is a study coming out of, sorry, let me get that to, so this is a study coming out of the United Kingdom, basically looking at 2,049 patients who were treated with immune checkpoint inhibitors across 12 centers. And data from the study was accrued from 2016 to 2018, basically looking at single agent immune checkpoint inhibitors or doublets for a few groups of tumors, namely melanoma, non-small cell lung cancer, and renal cell carcinoma. I think prior to this, there have been data, specifically subgroup analysis from a number of clinical trials looking at the role of immune checkpoint inhibitors in older adults. Most of them have reported subset analysis for older patients in terms of efficacy, but very little is known about toxicities. So this was a very timely real-world outcome study. So in short, patients who were aged 75 years or above 75 years treated with anti-PD-1 therapy in the standard of care setting derive similar benefit to younger patients. So efficacy data somewhat confirmed what we knew prior to this, which was these patients benefit as much as their younger counterparts in terms of efficacy. However, in terms of toxicity, patients treated with single agent PD-1 ICI therapies had similar tolerability as well. So this is very good data that supports the use of these therapies in older adults. You will, of course, hear a lot more later on when Dr. Steer will be talking to us specifically on this topic of immunotherapy in older adults. Another resource I would recommend would be this one. It's a JCO series, special series published in the middle of this year. And we looked at a number of different systemic therapies in older adults. So this particular article I've written together with my co-authors there, including Carolyn Presley and Melissa Wong, specifically on immunotherapy in older adults. So it's a review paper. We had also done similar review papers for targeted therapy and systemic therapy as well. So if you have time, this is a series of articles that I would recommend you read. Now, another interesting study that was presented at ASCO this year builds upon some of the data that was presented at ASCO 1 year ago, mainly looking at the role of GA and its intervention in older adults with cancer. So this was called the 5C study coming out of the Canadian group led by Martine Putz. And the study design, basically these patients were enrolled, about 350 of them were enrolled across 8 centers all over Canada. And they looked at baseline QOL, IADL, G8, and EQ5D scores. And they were then randomized to an intervention arm where they had minimum monthly phone calls by a registered nurse for 6 months and reassessment by the doctor as needed, or the control group, which had usual care. And the outcome of the study looked at quality of life, specifically the EORTC QLQ C30, each month for the first 6 months and on month 9 and 12. Unfortunately, the study did not meet its primary endpoint. There was no quality of life benefit for geriatric assessment and intervention, which was surprising because the studies that were presented the year before, at least 3 of them had shown significant improvement in terms of quality of life. And 2 of them have been recently published, and I'll talk to you about them in a short while. One of the reasons the authors gave for why this was so was perhaps due to COVID, because of the dropout effect, specifically in the intervention arm, that made it difficult to actually assess quality of life, and indicating there were non-random missing data as well that had caused these results, which were surprising. Nevertheless, I guess we'll have to wait for the final publication to see what actually happened in this study and why this was so. SIOC had a number of important publications, but I think the most important of which was probably this, published very early this year in January in Lancet Oncology, an update to the 2011 SIOC 10 priorities. At that point in time, Dr. Martine Exterman had come up with 10 priorities covering 3 key areas: education, clinical practice, and research. This time, a decade later, the group has now updated those 10 and it's become 12 priorities listed here. As you can see, there's an additional pillar now, which is collaborations and partnerships. And the key thing about these priorities is that the hope is for oncologists across the globe to see how they can prioritize their resources, use this to get policy initiatives going within their respective countries. Of course, it is not easy to implement every single one of these priorities, but based on what the current geriatric oncology environment is within your country, it may be a useful document for you to look through to provide some kind of outline or a template to follow in order to achieve some of the goals that we hope to achieve for our older patients with cancer. So if you have time, again, this is a document that we would recommend you read. Now, briefly to run through the JGO Artiuria Award winners, this was recently presented at our annual meeting. So this award was named after a renowned geriatric oncologist, was a giant in the field. Unfortunately, we lost to an unfortunate accident a couple of years back. And it is in honor that JGO named this award for up-and-coming geriatric oncologists and research that we feel that JGO felt was important to highlight. So there were two winners this year. The first one was from Denmark, and that was on the impact of tailored follow-up intervention on CGA in older patients with cancer. It was a randomized control trial. And the other one was something that came out of the United Kingdom, looking at treatment choices for older women with primary operable breast cancer and cognitive impairment. It was a prospective multi-center cohort study. So I'm going to spend a bit more time on two, what I would consider pivotal papers in the field of geriatric oncology. So these studies actually have changed clinical practice and bolstered support for the role of GA in older adults with cancer. So I'll first start with the one published about a month ago in The Lancet by Dr. Mohili and her team at the University of Rochester. It was an evaluation of geriatric assessment and management on toxic effects of cancer treatment, or the GAP-70 study. So a cluster randomized study. Now, the basis behind this was the fact that older adults have comorbidities, disability, geriatric syndromes, all related to aging. And the goals of treatment in the palliative setting would be to minimize toxic effects, maximize function, and improve quality of life. So with that in mind, the group then went about a nationwide to create a nationwide cluster randomized control trial with a plan to evaluate providing geriatric assessment summaries with management recommendations to oncologists in order to improve clinical outcomes for older adults with advanced cancer. Patients were recruited from practices from University of Rochester, NCI Community Oncology Research Program, which is a national network in the United States. Now, eligibility criteria, here patients who were 70 years and older were enrolled into the study. They needed to have one or more geriatric assessment domain impairments apart from polypharmacy. They had incurable advanced solid tumors or lymphoma, planned to start a new cancer treatment with high risk of toxic effects within 4 weeks, and more than one chemotherapy agent or non-chemo agent with more than 50% prevalence of grade 3 to 5 toxic effects, as determined by the primary oncologist, were the inclusion criteria for patients to be eligible to enroll into this study. Geriatric assessment were done according to the domains that many of you are familiar with, so it's all listed there, and they were then randomized to receive either recommendations on treatment interventions based on the GA or the control arm, which had standard of care with no recommendations. The primary outcome was to see the proportion of participants who experienced grade 3 to 5 adverse events within 3 months of initiation of treatment. Secondary outcomes included effect of GA on treatment intensity and on survival. So in terms of patient characteristics, it was relatively well balanced. There were more Caucasian or non-Hispanic white patients in this study than other races. GI was the most common cancer type seen, followed by lung cancers. And in terms of physical performance, they were relatively well balanced between both arms as well. However, there seemed to be more patients who had cognitive issues or social support issues in the geriatric assessment intervention group compared to usual care. Similarly, there were slightly more patients, 30%, who had previous chemotherapy in the geriatric assessment intervention group, compared to just 22% in the usual care group. Nearly all, or 90% of these patients had stage 4 cancer. And the number of impairments or number of impaired geriatric domains were on average about 4.5 and balanced between both the arms. Now let's head on to the results. So here you can clearly see that patients in blue were those in the geriatric assessment intervention group actually had fewer toxicities or grade 3 to 5 CTCAE toxic effects over the 3 months compared to patients in the usual care group. 51% in the intervention group versus 71% in the usual care group. And when you break them down into hematological and non-hematological toxicities, clearly you can see in both these areas, the geriatric assessment intervention group had fewer toxicities experienced over that 3-month period compared to their counterparts in the usual care group. Now, in terms of chemotherapy use, the most commonly used agents were taxanes and platinums, and a high proportion of patients in the intervention group received less intense combinations. As you can see here, in terms of single agent chemotherapy, 23% versus 18% in the usual care group. Both groups had planned use of GCSF prophylaxis, and those numbers were similar across both arms. Now, in terms of treatment intensity, when you look at the prevalence of reduced dose intensity at cycle 1, it was higher with the geriatric intervention group or assessment intervention group versus usual care. However, at 3 months, that had reversed. And this is likely related to toxicities and the need to actually reduce dose for the group that had usual care. And overall, on average, there was still a lower relative dose intensity, or at least a mean RDI for patients on the geriatric assessment intervention group. In terms of overall survival, there was no difference. So in spite of having lower doses at the start for those in the geriatric assessment intervention group, it did not impact survival. Now let's look at other outcomes. So common geriatric assessment guided management recommendations included more frequent toxicity checks, changes to treatment schedule or dosing, medication reconciliation, providing education materials, referrals to allied health. So these were the type of management recommendations that the geriatric intervention group had versus standard of care that less likely had these kind of interventions. What I want to highlight here is that there were a few things that were found to be different between the arms over that period. Over the 3 months period, there were, in terms of falls, there were fewer falls. In terms of number of overall medication used or discontinued before starting cancer treatments was also lower with the geriatric assessment arm. And also the number of prescription medications discontinued was lower as well before starting cancer treatment regimens. So a few discussion points. It met its primary endpoint. The study met its primary endpoint with the intervention reducing risk of serious toxic effects by 20%, reduced dose intensity, did not compromise survival, and also fewer falls, more medications discontinued, and reduction in polypharmacy. Also providing relevant information about geriatric patients can improve upfront decision-making because these patients are underrepresented in clinical trials. Hence, they're vulnerable to receiving treatments that have higher or greater risk than benefits, causing them lower rates of treatment completion and early mortality. Now, there are some limitations. Interventions were only done once at a single time point, and low-intensity interventions were delivered by oncologists and not geriatricians. This, however, may not be a bad thing because in many institutions, there are not enough geriatricians to actually assist with these things, so it can be something challenging. Now, the study was not designed to examine non-inferiority of treatment between the study groups, and oncologists determined toxic effects which might have led to bias, although there were attempts by the investigators to reduce this bias by having a masked clinical team at the research base to review toxic effects apart from the primary oncologist. Response rates and patient-reported outcomes was another bias as well, because higher prevalence of patient-reported outcomes might have led to this. For example, higher reporting of falls, and there was a selection bias, especially exposure to chemotherapy arms were to both arms were different, slightly higher the intervention group versus slightly lower in the usual care arm. So in conclusion, GA and assessment and management should be considered standard of care in older patients, and this can be help reduce treatment toxicities as well as fall and polypharmacy. Quickly going to go through the next study, which is GAIN, which was also published not too long ago. One of the few studies that was presented at ASCO last year that, of course, drew a lot of attention because of the data that has come out from the study. So it's a randomized controlled trial, and it was done to evaluate efficacy of specific geriatric assessment-driven interventions versus standard of care on chemotherapy-related toxic effects and other clinical outcomes as listed right in front of you. Now, patients enrolled were slightly younger, so they had to be 65 years and older, unlike GAP70, where they were 70 years old. Again, solid malignant neoplasms of any stage, not just advanced stage, and starting new chemotherapy regimens. These patients were found to fit this criteria, were eligible. They then got on to getting a baseline GA, a SPICES assessment, which I'll describe in a short while, and a CARC chemotherapy toxicity risk score. They were then randomized in a 2-to-1 fashion to either the GAIN arm or the standard of care arm. And subsequently, they were followed up for duration up to 6 months from the start. So SPICES involved looking at certain kind of, geriatric assessment criteria, including sleep disorders, problems with eating, pain, incontinence. So these are all geriatric syndromes. So patients were assessed according to this list there with interventions for them as well. And the CARC score is something many of you will be familiar with. Again, something led by the late Dr. Ati Huria. And patients had this at baseline before initiating therapy. Now, those in the GAIN arm had MDTs done on them, referrals were written when they had deficits to intervene on, and chemotherapy had additional support from a nurse practitioner. While standard of care just had chemotherapy and referrals were done at discretion of the oncologist. Now, these were some of the interventions briefly, so you can get this from the paper itself, so I'm not going to go through in detail. So I'm just going to give an example. As you can see there, for functional status, those who had limitations had exercise prescription, they had evaluation for fall risk, home safety evaluation, gait strengthening, and some Reiki therapy. So study outcomes were primary outcome of incidence of grade 3 or more chemotherapy-related toxic effects, and secondary outcomes listed there, including advanced directive completion, ED visits, unplanned hospitalization, early discontinuation, and so on. In terms of patient characteristics, as you can see, age range there showed that some were very old, up to ages of 91, mainly female patients, white, and again, GI cancers predominate amongst them. And most of the patients were stage 4, although there were also some patients who were stage 1, 2, and 3. In terms of interventions, you can see here, out of the 3,971 potential interventions, about 76.8% were implemented in the GAIN arm versus just 12.5% in the standard of care arm. Now, when you look at grade 3 or higher chemotherapy-related toxic effects, or the primary outcome of the study, it met its primary outcome. Patients on the GAIN arm actually had fewer hematologic and non-hematologic side effects, and this was clinically and statistically significant. As you can see here, the common hematological side effects included anemia, neutropenia, and non-hematological side effects included infection, fatigue, and hyponatremia. The other secondary outcome that was met was an absolute change in advanced directive status. In terms of survival and analysis, again, not very different between both the arms. So in summary, there was a significant reduction of more than 10% in terms of grade 3 or more chemotherapy-related toxic effects, and more likely, these patients on the GAIN arm were more likely to complete the advanced directives, and this did not impact overall survival compared to standard of care. There's some limitations with a single tertiary center study where MDT was available, and there was potential bias from patients and treating oncologists who were aware of the treatment assignments. So with that, I've come to the summary of my talk. So recent robust real-world data supports the use of immune checkpoint inhibitors in older adults with Cancer, and Dr. Christopher Steele will be talking to you about this shortly. Updates to the SIOP priority statement makes it an important document to help lead policy changes in the field globally. 2 large randomized trials were published in high impact factor peer-reviewed journals highlighting the benefits of GA and intervention on quality of life and reduction of chemotherapy-related toxicities. And SIOP leads the way in educating cancer specialists across the globe in the latest development of GO. In the last minute, I'm just going to talk to you briefly about SIOP. Some of you are familiar, some of you may not be. This is probably the leading organization for geriatric oncology globally. We have over 1,700 members from 80 countries. And yearly, we come together at an annual meeting to share and discuss latest research and development in geriatric oncology. We also conduct some advanced courses, and I'm going to talk a bit about that in the next slide. This is the history. We were established more than 21 years ago, started by Dr. Paul Calabresi and some of the doctors that are listed there. And for the first time this year, we have a leadership from Asia, and I hope with that it will stimulate interest specifically in countries in the region like India. And I've seen a lot of wonderful activity coming out of India specifically over the last 2 years, and I hope this will continue in time to come as well. So I'll talk a bit about the advanced course. So for some of you who are interested on some of the key principles of geriatric oncology, so this runs over just 2 days and it's virtual, so you can sign up for it online. So please feel free to get on our website and sign on to this course if you want to know more about geriatric oncology and go a bit into some depth in learning about some of these principles and how you can apply them for your patients in your own clinical practice. The other thing is please join us as a SIOP member. Again, the membership rates are also, we have special membership rates for patients, for oncologists or scientists from low middle income countries. So to make it attractive for all of you to join, so please do consider joining us as a member. With that, I'd like to thank you for your time and your attention.
Thank you very much, Dr. Ravindran. That was really a very comprehensive review of the publications in the last year, which really stressed the fact that there has to be an increasing recognition of geriatric assessment as a part of our treatment protocol. There is, however, something glaring. As a radiation oncologist, I'm mentioning this, that there seems to be very little attention outside the medical oncology space in the way treatments have to be modified and the way patients have to be assessed for surgery or for, so there's there are publications out there that tell us that, treatments have to be modified and perhaps outcomes are impacted. And yet, it's not come together as nicely as it has in medical oncology. And what would you have to say about that?
Interesting comment, Dr. Nanja. And I think there is some truth to that. I don't deny the fact that the development of geriatric oncology in other non-medical oncology related areas may not be as mature or well developed. But while saying that, I think it's a growing space. So within SIOP, we have interest groups. So we have an interest group for geriatrician, for surgical oncologist, because surgeons have been using these tools for a while now as well for older cancer patients in the peri-operative space. So some call it prehab. That means just before surgery, they actually undergo geriatric assessment and intervention to get them fit. And there's a lot of outcomes that have been shown to have improved from this kind of interventions. Radiation has similarly come into the place as well. So there's a radiation interest group that you may want to consider joining. And that group is looking at multinational studies like this. I think sometimes the key thing is collaboration. To do these studies within a single center is very hard. You may not get enough patients and support. And so that's the short answer.
Right. I'd just like to mention here that we are writing up a pilot. I work at the Proton Center in Chennai, and we are actually writing up a small pilot to put all the patients who come to the hospital through a geriatric, all patients above 65 through a preliminary geriatric intervention. We have a geriatrician visiting us as a regular clinic, and we hope that in the radiation space, there'll be something that we'll be able to put together. Are there any comments, please, from any questions or comments?
Yeah, I have a question, sir. In palliative setting, after geriatric assessment, what we are seeing, we are decreasing the dose in most of the patients. But is there anything like that? The number of patients undergoing
Sorry, could you repeat that? Meaning by giving them lower doses because of geriatric intervention, does that increase best supportive care? Is it? Sorry,
No.
I need a.
So my question is that the number of patients undergoing best supportive care, have
Yes.
they also decreased after geriatric assessment? Are we treating more patients though with a modified dose?
Okay, that's a very good point. So the role of geriatric assessment is to personalize. A lot of it is done by ECOG, so it's quite, I would say, rough, right? It's not refined. And by doing that, yes, we may be actually putting people into the best supportive care box when they could be getting modified intervention. Usually, it is not the clear-cut best supportive care group, it's the vulnerable group. Broadly, when we do these assessments, patients will be classified into three groups: the fit, the unfit. The unfit will be best supportive care, and the vulnerable group. And the vulnerable group can be, put into the fit group if they undergo some form of geriatric intervention. And only with geriatric assessment, some of them can be assessed appropriately enough for us to know what to do with these patients. Give modified treatment or intervene, maybe even give potentially full dose treatment. So to answer your question, the answer is yes. Geriatric assessment will reduce the number of patients who we may have given up on and placed under the best supportive care group. And some cases we have because of age. So patients become relatively fit, but they come in with the case notes writing that they're 85 years old or 90 years old. You immediately have these kind of preconceived notions that they're going to have all these comorbidities. They may not be, physically able or have the support that's required for these systemic therapies. Yeah. But conversely, we may be also giving some of these patients who are less fit and should not be getting full dose of treatment based on the fact that they walked into the room, they looked fit, but they have 10 comorbidities, multiple drugs that they are on, and organ function that may be deranged. But then just based on eyeballing them, which was what a lot of us do because of lack of time and knowledge about geriatric assessment, may unnecessarily cause harm. So you must think about the converse as well. But it's less likely that, and more of us giving up on patients who should be getting therapy.
So one more question, that the toxicity profile of the immune checkpoint inhibitors and chemotherapy are slightly different. So if we have an option to use both, so what do you think one should prefer in the geriatric age group? Is immunotherapy more easier to give in this group of patients? Such as we see in our head neck cancer patients, if they are elderly, we are not keen on giving them chemotherapy. Might be giving immunotherapy, we find it slightly safer in this group of patients. Your opinion on that, sir?
So I think you have to go back to first principles. So that would mean what is standard of care for anyone, regardless of age, right? So once you have that in mind, and for the example you gave will also apply for lung cancer as well, right? For those patients in the first line who are non-oncogenic driven lung cancers, it's IO plus systemic chemotherapy. Now, that's where geriatric intervention comes into the picture. If, based on that assessment, patient is found to be fit, there's no reason to decline them the combination IO chemotherapy just because of age or other factors. So I think slowly you need to remove age out of your thinking process and go to geriatric assessment as what helps you define who is fit and who's not fit. Bottom line is, if a person is fit to receive combined IO chemotherapy, they should get it because data has shown that will benefit them the most. So we shouldn't deny them the chemotherapy because we think that they may suffer more toxicity. We should actually do these assessments and assess their toxicity risk first. And based on that, make the call on whether they should or should not get the chemotherapy element. Of course, IO is generally well tolerated. I think a lot of data supports its use in older adults without a lot of assessments being required. But If combination therapy is standard of care, patient is fit, they should get standard of care.
Thank you so much.
Thank you very much, Dr. Ravindran. I'm sorry I'm having to call a stop to this very interesting discussion because we have run out of time. And please continue to discuss in the chat box.
So, Dr. Nangia, may I ask one last question of Dr. Kaneswaran? My apologies.
Please.
Thank you so much for a really eloquent update on all the major breakthroughs in geriatric oncology and so rapidly. I have a little bit of a controversial question for you. I think based on the GAP 70 plus and the GAIN study, we know that toxicity reduces. And I think from GAP 70 plus, we got a sense that it was primarily from dose reduction. In our setup, at least, we are seeing that we are not really able to do a full geriatric assessment for a lot of our patients. So would you recommend, based on that, taking a leap of faith and saying, just if you aren't able to do a full geriatric assessment and the patient looks a little bit frail from your eyeball test, just upfront dose reduce and then build up gradually?
That is a safe strategy. So I would say that's a good idea. But what maybe a middle ground is consider a geriatric screening tool, like G8 or something. Takes a couple of minutes and something they can do, while waiting outside a clinic, or the nurses can administer as soon as, any patients above 65, automatically you get your nurses to just do a G8. Gives you a rough idea rather than eyeball, because I think any tool out there, and that's why we have moved away from the term comprehensive geriatric assessment to geriatric assessment. Because I think any tool that you can use out there within the limitations, and I can understand where you're coming from, Vanita, because a lot of us practice in clinics in Asia that are chock-a-block full. We don't have the luxury of doing a full geriatric assessment or sending to a geriatrician. So we need to come up with methods that are, quick and easy and adds value to the eyeball test. So I fully agree with what you said. It's safer to go with something lower and then push doses up, because it is in the palliative setting, of course, and quality of life is paramount. So it's a great strategy, but I think if you can spare the 2 to 3 minutes, add on a screener, and that may help you a little bit in making the call.
Thank you. Thank you. So can we move to the next session now? And the next session is on leveraging technology to advance geriatric oncology. And we're happy to have Dr. Enrique Soto Perez de Celis, who's a geriatric oncologist, and we're aware of his participation in the recent GAIN study. He's from the Department of Geriatrics. I'm sorry, I may not be able to pronounce this properly, but the Instituto Nacional at Mexico City in Mexico, and also a member of the ASCO Board of Directors. Welcome, Dr. Enrique.
Hi, thank you so much for having me. It's a pleasure. So it's not the first time I've been at this conference, so it's a great pleasure to be here again and to be back. And you did a great job introducing me. It sounded great. So my name is Enrique Soto. I'm an oncologist, and I specialize in geriatric oncology at the National Institute of Medical Science in Mexico City. And today I'm going to talk about the use of patient-generated data to guide decision-making in older adults with cancer. And I think this is a very relevant issue, particularly in developing countries like India and Mexico, because I do believe that we have a great opportunity to use information technology, and particularly the great availability of smartphones and of mobile internet connections to help us better understand our patients, how they are experiencing treatment, and how to provide the best quality of care for them in geriatric oncology. I have no financial conflict of interest to disclose. So the way in which we care for our patients is changing. And this has been accelerated during the COVID-19 pandemic. So before the pandemic, and traditionally, the consult has happened in the clinic. So we see the patient face-to-face, we take notes, we examine the patient in an office environment. But today, and with COVID-19 particularly, we've changed to a more virtual environment, like the one we have today, in which we see our patient through a computer screen or through a smartphone. And although this may have some shortcomings, it also has some promises. So there are strengths related to the use of digital technology and to the use of telemedicine. And some of these are the capability of having more intensive and robust monitoring of our patients. So we are able to potentially detect toxicity earlier and to identify functional decline earlier as well when patients are getting treatment. And we are also able to support or provide an earlier provision of supportive care services. And again, this is an opportunity to foster self-management. So we do have a new channel of communication with our patients that is constantly there and that allows us to allow our patients to have a better self-management strategy than we could have in the clinic when we only see our patients every 2 or 3 weeks. Patient-reported outcomes have shown to improve the outcomes of patients with cancer. So this is a study that was presented by Ethan Bash a couple of years ago. And in this study, conducted at Memorial Sloan Kettering in New York, they used a patient interface for the self-reporting of symptoms. This happened online or through telephone systems. And what they showed was that patients who were able to actually report their own symptoms and tell their physicians about how they were feeling at home had better quality of life, had reduced hospitalizations, and in fact, this led to improved survival. So patients that were actually able to report their symptoms in real time through web-based systems were able to get better care at an earlier stage, and this led to improved quality of life and to improved outcomes. However, this happened in a setting that was very controlled. So these were younger patients, the mean age was 61 years, and this happened at Memorial Sloan Kettering, which is one of the largest and best prepared cancer centers in the world. So of course, the outcomes of these are not necessarily transferable to what we see in low and middle income countries like India, Mexico, Brazil. This is another great example, a study conducted in France of patients with lung cancer that were able to report their symptoms using an online system, and patients that reported their symptoms using the system were able to get treatment at an earlier stage, and this led to improved survival. Again, this happened in a population in cancer centers in France that had mostly a younger age and that was able to access highly specialized care. So again, this is not necessarily something that we can extrapolate to the everyday life of our patients in Mumbai or in Mexico City. So what are the barriers for this type of setting? So what are the barriers for us as physicians practicing in low and middle income countries for implementing this type of studies or this type of strategies with patient-reported outcomes? The first is building a system itself. This is not something that is feasible in most areas of the world. The other is the integration into medical records. So many of these studies had these systems integrated into their electronic medical records. We know that in many settings in developing countries, there's not even an electronic medical record. A lot of people are still doing their things in paper. These studies or these strategies had dedicated full-time personnel that was able to check the website, answer the phone calls, solve patient issues. Most patients had internet access, and most of these patients had an elevated health literacy. So most patients with cancer in Memorial Sloan Kettering have a college degree or higher, and we know that in low and middle income countries, many of our older adults have elementary school or middle school education. So this may not necessarily apply everywhere. So the main question I want to answer today is how can we tackle these barriers for older patients with cancer using innovative technology and patient-generated data without the need of having very complex systems for monitoring? And I think that one of the answers is the use of the Internet of Things. So the Internet of Things is a series of physical objects that are embedded with sensors. These sensors have a processing ability and are able to connect with software in order to provide ubiquitous computing. What this means is that many physical objects like wearables, watches, even clothing can connect and exchange data with other devices in order to monitor some very specific and very important vital parameters for patients, such as pulse, temperature, weight, step count, activity, pulse, and all of these can lead to emergency notifications that physicians can act upon in order to provide better care for patients. What would a framework look like? A couple of years ago, we published a study in JCO Clinical Computing, and there is a framework for using the Internet of Things in order to monitor a patient. One source of information is self-report, so patients can actually go and self-report their symptoms to web portals, as we saw in the studies from Memorial and from France, or through the use of smartphone apps. But the other is the use of Internet of Things. The advantage of Internet of Things is that it doesn't actually require patients to do anything. It only requires them to live their lives as usual, and they are able to generate the data on their own. And this can be obtained through wearables, smart homes, the use of smart scales, or blood pressure monitors, the use of e-textiles, which are clothes that can actually sense body composition or sweat, or smart objects, such as, again, scales, heart rate monitors, etc. This information can be used for a couple of things. One is symptom monitoring, so this can be related to symptoms due to the cancer or to the use of chemotherapy, such as adverse effect assessment, and also through the obtention of physical activity data, which we know is very important to assess the activity an individual is taking, and the toll both cancer and its treatment are taking on a specific patient. And all of this information can be processed through machine learning and data processing. It is important to understand that all of this information represents hundreds of thousands of data points. So if we are going to use digital technology to obtain information for our patients, we actually need to develop the platform to use this data and to integrate it in a way that can be interpreted. These are literally hundreds of thousands of data that on their own are impossible to understand. After we process this data, how can we use it? So there are a lot of things we can do using this wearable technology and the Internet of Things. We can do posture detection. We can do task completion. We can actually understand how our patients are able to complete tasks that are needed for everyday activities. Sleep monitoring, the monitoring of everyday activities. We can use step counts, which are a proxy of everyday activities. We can analyze gait. We can make an analysis of energy expenditure, and we can actually look at the detection of falls and see if our patients have fallen in the last hour. And all of this can be integrated and visualized by physicians. So how can this look? So we could actually, in the future, be looking at our patients, hundreds of patients that are getting treatment, and be looking at their posture, their sleep, their gait. And this is something that I believe can actually be done across the world, even in low and middle countries like ours. So what are the advantages and the disadvantages of the use of the Internet of Things? The advantages are that this produces objective patient-generated data that is useful for populations who cannot complete questionnaires. So if our patients can actually self-report their activities, perhaps self-report is the way to go because it's easier. But for patients that cannot do that, the Internet of Things is a potential solution. In contrast, these types of solutions may be expensive or difficult to obtain in some settings. So even today, in countries like India or Mexico, etc., providing patients with smartwatches or with VivoFit devices, etc., may not be cheap enough in order to make this achievable for everyone. So a very important thing for researchers, because I know that many of you are interested in this type of things, is how do we design, plan, and study this type of interventions? So how do we actually take these digital solutions, this Internet of Things, and adapted to patient-centered studies. And I want to highlight this very interesting paper by Armin Shalakhny, which was published in last year's ASCO educational book. And this review, and I encourage you to read it, highlighted the steps necessary to conduct a study using patient-generated data and patient-generated information using the Internet of Things digital solutions. So the first thing we need to do is to select health concept of interest. What are we going to look at? Are we going to look at function? Are we going to look at pain? Are we going to look at cognition? And after we select that health concept of interest, we need to identify metrics that measure the concept. So if we are going to assess activity, then perhaps we need to measure gait, we need to measure gait speed, steps per day, etc. So we need to select a concept and then to identify metrics that are validated and measure that specific concept. After that, we need to find a suitable device that is clinically valid. So if we're going to measure steps, then perhaps what we need is a smartwatch or a smartphone with a very good accelerometer that is able to measure what we want to measure. The next step is to develop an analytic plan, because we're going to obtain 1,000 data points, hundreds of thousands of data points. So we need to develop an analytic plan before we even start the study in order to interpret those data. And finally, we need to utilize appropriate studies. So this is very important, and I think that for all of us researchers working in low and middle income settings, where there are a ton of smartphones, apps, etc., we need to have this in mind before we even start developing our studies. How are we going to select a concept of interest, identify metrics, find a suitable device, develop an analytic plan, and then use appropriate studies. Here I show you some examples of studies using wearables in oncology. This is a study conducted at City of Hope by Virginia Sun and her colleagues. And what they did was a very simple thing. They used wristband pedometers in patients with cancer who had undergone abdominal surgery. And they compared it with what they usually did, which was the use of surveys that were completed electronically. And they saw that the use of this wearable device had a higher adherence than the completion of surveys, and that daily steps were actually associated with surgical complications. So patients who, after undergoing surgery, went home and walked very small distances, had very few steps, were far more likely to have complications than those patients that, after going home, walked longer distances or were more. So this is a great example of the use of digital technology and wearables to understand how our patients are undergoing treatment and experiencing the side effects of treatment. Another great example of the use of digital technology is the Psychware system. So this was presented by Dr. Peterson and colleagues in ASCO and also published in JNCI monograph. This was a study undertaken at MD Anderson. And what they did was to develop a home-based system called Psychware, in which after patients underwent surgery for head and neck cancer, they were at home and they had an entire Internet of Things installed at their home. They had an internet-based weight scale, blood pressure monitor, pulse monitor, etc. And so the researchers were actually able to monitor the weight, the body composition, the pulse, the blood pressure of the patient after they went home. And this was coordinated or integrated with patient-reported outcomes. And they conducted a randomized clinical trial in which over 300 patients who had received radiotherapy for head and neck cancer, which I know is highly prevalent in India, were randomized to Psychware monitoring, in which physicians check the vital signs and the weight, etc., of the patients daily, in contrast with usual care in which patients went to clinics. These were patients that had a median age of 60 years, and the main objective was the self-report symptoms. What they saw that was that patients who had an Internet of Things-based monitoring at home had an improvement in general symptoms, so symptoms were detected earlier and acted upon earlier, and this led to an improvement in head and neck symptoms that was long-lasting, even weeks after treatment. So having patients monitored closely at home actually leads to improved outcomes. And I think this is something that's very useful, particularly in settings like ours, where patients are not able to have direct contact with physicians or come to the emergency department as easily as they could potentially have in more developed regions of the world. So regarding the current status of wearables in oncology, this is a very interesting systematic review that was published recently, in which 25 studies were identified, mostly including patients with breast cancer. Most studies using wearables in oncology were pilots for observational data and had mostly feasibility outcomes, and the most commonly used sensors were accelerometers. And what most authors report was adherence. So adherence is very high to accelerometers. If we give a patient an accelerometer or a sensor, it is highly likely that they will use it. So I think the main barrier is not that patients use it or not, but how we interpret this data and how we use it to make everyday clinical decisions. What types of sensors do we have? So we have all types of sensors, going from very simple wristbands, such as these, to more complex devices like the Garmin VivoFit, which is highly used in many studies. Even the same smartphones can be used like a contained device that actually has the accelerometer in it and can also transmit the information. And some studies have used more complex devices like these armbands that can actually measure blood pressure, temperature, etc. So we can go from very simple sensors to very complex ones. So why is this an attractive concept for global oncology, and why is this something that can be very attractive for researchers working in low and middle income countries? Well, this is a way to tackle geographic and cultural barriers. This is something that we can make accessible for patients living in remote rural areas, because we know that in many parts of the world, there are more phones than people. This also solves the fact that in many areas of the world, there is a lack of personnel with geriatric training. There is a lack of telephone triage systems and of web portals. And in many places, toxicities are not detected in a timely manner. And this is particularly relevant for vulnerable older adults. So I think this is something we can all relate with. In many times, we see patients that come to clinic, we give them chemotherapy, they come back 2 or 3 weeks after, and they tell us that they felt terribly bad for 2, 3, 4 days at their home, but they had no one to call. And then they come back to us after they had severe toxicity, and this may lead to decreases in functional status, and this may decrease our ability to continue providing chemotherapy. So the earlier detection of chemotherapy is relevant for many of our patients. So why is mobile technology an innovative solution and an ideal solution in my perspective? Because it's an optional communication strategy. This can allow for the remote assessment of toxicity. And there is emerging data from patients in developed countries. So even though people are doing this in the developed world, this is hard to extrapolate to developing countries like ours. So I don't think that it's a huge opportunity for us as researchers to develop this strategy. And there are 2 interventions developed specifically for older adults in low and middle income countries, particularly because there are concerns about technology literacy. So whenever we think of a study that mixes older adults and smartphones, older adults and information technology, there is always this concern about how older adults will be able to use this technology and to be able to adapt it. And why is this important for the developing world? Well, as you can see, most of the world's smartphones are in low and middle income countries. So India, in fact, is one of the largest consumers of smartphones, and many of the top 10 countries in the world using smartphones are low and middle income countries. So India, Brazil, Indonesia, Mexico, we have a ton of smartphones. So this is a huge opportunity and a great platform for interaction with our patients. So how can a smartphone be used to detect, for example, chemotherapy toxicity? So we know that functional decline is a marker of toxicity in older adults with cancer. And we also know that mobility can be measured using the sensors available in commercial and that a ton of our patients have. So what we wanted to do, and I'm going to talk about what the research we've done in Mexico, we wanted to analyze whether functional decline measured using a decrease in the number of steps per day could actually be or represent a novel method for detecting toxicity in older adults getting chemotherapy in a developing country, in this case. So in order to do this, we developed a study in which we included older adults, 65 years and older, who had any solid tumor and were starting chemotherapy in any setting. And what we did is before they started chemotherapy, we collected their sociodemographic data, their tumor and treatment characteristics, and a geriatric assessment. We conducted this geriatric assessment that had all the features that you already know. Before they started chemotherapy, we gave them a smartphone and we recorded the number of steps per day using the Google Fit API, which is something that is freeware and very easy to adapt. At the start of chemotherapy, we gave side effect education as per standard of care, and then we asked the patient to use the monitoring system for 1 cycle. And in any patient that has a declining number of steps of 15% more from their baseline recording, we call them, we assess their toxicities, and we implemented interventions. At the end of the cycle of chemotherapy, we conducted a new geriatric assessment with obtained patient feedback. So we assessed 52 patients for eligibility, 40 patients were included in baseline recording, and those 40 patients, all of them completed follow-up. So as you can see, these patients are probably very similar to what you see in India. They had a median age of 72 years. Most of them had advanced disease. 60% had less than high school education, and only a quarter had previous smartphone use. Interestingly, a lot of patients live very far away from a hospital, some over 1,000 kilometers away. Looking at their geriatric assessment, many of them were dependent in their instrumental activities daily living. Many of them had physical impairment. A lot had nutritional impairment, so many had lost weight. 2/3 were living alone or with another older adult. And approximately a third had impaired hearing or impaired eyesight. And despite all of these issues, many of them or most of them were able to actually use the smartphone and send us data using the smartphone. So on average, we recorded 11 days before the start of chemotherapy, and the median number of steps per day for our patients were over 3,000. Here I show you the feasibility. So we looked at the number of days of each chemotherapy cycle in which the patients were actually able to send us their steps. This was conducted automatically. So most of the patients were able to, or most of the subjects we were able to obtain their steps, and most of them considered it very acceptable and very important and feasible for them. Regarding a decreasing number of steps, we found a decreasing number of steps of 50% of total chemotherapy days, and on those, in 30% of days, we detected some type of toxicity that was potentially actionable. 60% of the patients had toxicities managed over the phone, 25% were sent for urgent medical care, and 12% of the patients were actually hospitalized after toxicities were detected using the smartphone. So we were actually able to detect toxicity earlier and to act upon it. So what does this show us, and how can we use this in developing countries like ours? So patient-generated data that can be obtained with smartphones or other Internet of Things devices can provide additional information that obtained from patient-reported outcomes. Sensors can measure almost anything and generate a great amount of data. And I know that countries like India are highly developed in the use of sensors or of digital technology. This can be a potentially useful solution to extend the reach of geriatric oncology in resource-limited settings. And a very important thing is knowing what sensors to use, what to measure, and how to interpret the enormous amount of data generated. And I want to leave you with this quote from Admiral Grace Hopper, which is from the US Navy. The most damaging phrase in our language is "we've always done it this way." So we actually need to change the way in which we assess and act upon the deficits we find in our patients. And we need to find a way to harness technology, simple technology such as smartphones, to provide better care for our patients. And I think it's something that is highly feasible in countries like ours. So thank you very much, and I'm happy to answer any questions you have.
Thank you very much, Dr. Enrique. That was really, I should say that you have, you've shown us, kind of given us a goal and also a crystal ball, all mixed into one. So thank you. That was really very nice. So are there any questions, please? I'm sure there are many. I'm sure there are ideas buzzing.
Thanks, Dr. Soto. That was really, really thought-provoking. Excellent. So, couple of questions for you. One is in the use of smartphones. So I know most people have a smartphone. My mother has a smartphone. The issue is that she doesn't keep it with her, by and large. So whenever I try to call her, I need to get through on the landline and then say, pick up your cell. So in terms of using it to count the steps, did you face any issues with that?
Oh, I think this is all an issue of communication, no? So one thing that we found, or one thing that is very evident to us, and I'm sure this happens to you in India, is that many of our patients feel alone. So they come to clinic, and at the time they're in clinic, they're with us, but then they go home, and when they're home, they do not have a system that supports them. So in developed countries, they have telephone hotlines, they can call a nurse, they can contact their physician, even through web-based portals. But in low and middle income countries like ours, if patients have side effects, they have to go to the emergency room, and this in some cases entails traveling long distance. So if you actually show patients or you educate patients that their smartphone can be a direct connection to their physician, they won't leave it behind. No? And this actually becomes a very important tool. And what we've seen is that patients actually feel that the smartphone connects them to their healthcare team, and that this is a companionship to their care. So I think that this is all a matter of communication. If they see the smartphone as their connection to their doctor, to their healthcare team, this is something that they will keep with them. And we actually showed that over 90% of our patients were able to send us their steps every day. We are now conducting a longer study, which we're following patients over 3 months. And so far, our experience has been great. So patients actually use this, and they feel that this is something that is taking care of them. So I think this solves this problem of our system being too limited to have continuous support for patients. I don't know if I have answered your question.
Yes. I think at least it's a roadmap, at least for us moving forward. Another question before I hand it over to the organizer. So, any data privacy issues? So, if you're accessing Google and you're accessing the phone and the step count and other things, are there any data privacy issues involved?
Yeah, so there can be. So, so far we've done this under a protocol, so patients actually sign an informed consent. But what we do is we inactivate the GPS tracking system. So I always say patients, I know how much you walk, but I don't know where you go. Because so I don't want to know where patients are going. So the order to do that is you inactivate the GPS, and you don't know where they're going, and you only track their number of steps. So in that way, there are ways to keep the patient's privacy and just detecting their physical activity.
So interestingly, the lockdown has actually led to more telecommunication and a certain comfort level on both sides. So we've actually done teleconsults of patients who've completed radiation and inspected their skin reactions over the phone. But I think what was interesting was, how you proposed that we integrate this with using prompts via phones. And that I think is really, I think, as Dr. Vanita said, very thought-provoking and definitely something that we'll all be contemplating.
No, I agree. I mean, we've done a lot of telemedicine as well, and I think it's a great opportunity. We've used a freeware platform, so most of my telemedicine clinic takes place over WhatsApp video call, and so most patients have that. If they don't have it, a younger relative has a smartphone with WhatsApp, and so this is a way to provide care to patients who in many cases are thousands of kilometers away, and we can see their hands, have them weigh themselves. So this is I think it's a great opportunity to extend the reach of our services, and this is something that has been accelerated by COVID. So if this was not acceptable before, now with COVID, it's more acceptable. People say, well, this is something I want because I don't want to go to Mumbai or Mexico City, etc., where there's a lot of COVID.
True. Thank you very much, Dr. Enrique. I think for reasons of time, we'll move on. And please do continue the discussion in the chat box and later on the panel discussion.
Ma'am, a single comment. May I go?
Sure.
Yes, sir, really in the last 2 years, what we have witnessed too, that most of our patients are on WhatsApp. And now the patients are too very much comfortable on WhatsApp call. So there are two aspects, that is the subjective one and the objective one. What we see is the patients have got their complaints, they can show us the scans. And what about their objective that regarding your pulse, blood pressure, we depends on ask them to get hold of a local practitioner or a local nurse and then get back to us with the vitals. But this aspect of using the smartwatches and other things, in India still the smartwatches are of Apple and other companies which are still too costly for a normal Indian being. Might be the Chinese version may start now promoting those so that we may get access to the blood pressure and pulse of these patients too. But do you think that generating so much data and so intensive monitoring, we should have a cutoff where we are going to intervene? When the patient complains, it means that they are changing the vitals and now they are complaining and then we are advising them. But just by the vitals monitoring and we are changing any treatment?
Yeah, so this is a great question. So I think that the first thing I want to tell you is 5 years ago, I told you, we're going to give smartphones to everyone. You would say, come on, that's crazy. It's too expensive. And now we can get very cheap smartphones. So I think that wearable devices are going to get cheaper. And in a year or two, even today, we can get very cheap wearables. So smartwatches are going to get very cheap. Everyone is going to have a smartwatch eventually. So we have to start planning for that. So regarding the data, we need more research about how to actually use those data in everyday clinical practice. So if patients are walking less, if patients are doing less physical activity, what the hell does that mean? And that's what we need to do. We need to work on that to see if that actually can lead to treatment changes. And we don't have that data yet. So I love having that data because I see that my patients are not walking enough. And usually the patients that are not walking enough are feeling worse. And I usually tend to focus more on those patients because I know that they need more care. But we need to actually produce the data to show others that these type of measurements are valuable. And I am sure they are, but I think this is something that we need to do, and that also researchers working in some countries have a huge opportunity to do this, because we are in a great position to use this type of easily available technology to improve the care of our patients, and we don't have the pressure of having to compete with other systems that are already established, like phone lines, etc. So this is a great opportunity. And for example, you guys that you see a ton of patients with head and neck cancer and things like that have a lot of toxicity from treatment, you have to start studying this, because I think you're in a great position to do this.
I'll have to call a stop here for reasons of time. So may I request, we'll start the next talk. I'll introduce the subject, and that's immunotherapy in older adults with cancer. And we have Dr. Christopher Steer with us, who's a medical oncologist at the Border Medical Oncology, Albury Wodonga Regional Cancer Center in Albury, Australia. an associate professor at the University of New South Wales Rural Clinical School in Albury. Professor Steer, please.
Thank you very much to the organisers for inviting me today. It's a pleasure to be with you. Hopefully you can hear me well. I will share the screen and be with you now. So this is my talk, and as you can see, my Twitter handle at the bottom. I'd encourage people to get onto the social media and follow the GeriOnc hashtag. It's a fabulous way of interacting with all with the world of geriatric oncology and feeling part of the family. This is my disclosure slides. I do a number of paid work for pharmaceutical companies, but the majority of my income is derived from the Government of Australia. This is the Albury-Wodonga Regional Cancer Centre, completed in 2016. And we service a regional catchment of patients from regional Australia. I'm going to be doing a bit of talking today about clinical trials data, of course, fairly dry, unfortunately, but what we're also concentrating on is the real world and some real world data. Of course, our older adults are more representative of the real world rather than the clinical trials. And as part of the real world in Australia, you can see that the median age of diagnosis of cancers is largely older people. These are a lot of common cancers that we see. And in Australia, the median age of diagnosis of melanoma is 66. Lung cancer 71, bladder cancer 76, and cancer of unknown primary is 78 years. So as you can see, with the median age of diagnosis of cancer in Australia at 68.4 years, cancer in older people is a major problem here. Where do I fit in? Where do I currently work? This is an opportunity to show that there's a map of Australia, for example, showing the incidence of melanoma, which you can see is in the north of the country. I live and work in the southeast in Albury-Wodonga. I'm in a practice where we map our data, and we have 17,000 patients which to map. And this is an interesting way of looking at it. This is the patients, as we can see, the average age on the bottom axis, up to 75 here, and this is the number of years that they've survived if they've died from their tumours. And the size of the sphere, if you like, is the number of patients that we've seen. And as you can see, our younger patients with brain tumours are down here, poorer survival and younger, and yet bladder cancer and cancer of unknown primary and lung cancers, some of the patients we're talking about today, have a poorer survival and tend to be older. In researching this talk, I looked at real world data and found, of course, that you are completely ahead of us, and you've published your experience in immune checkpoint inhibitors. And it was interesting for me to see the age breakdown, the patients that you've treated and the drugs that you've used. And it was intriguing to me to see that melanoma, which unfortunately is a fair feature of my talk today, isn't included in the cutaneous melanoma section, and I presume it's a relatively rare condition in your country, but not so here, unfortunately. So let's talk about our case to ground us. This is Mr. IH. He's 89, and he had a metastatic melanoma on the sole of his foot. He had noticed lymphadenopathy when he was 87 and commenced single-agent pembrolizumab at that point. He was in complete remission on FDG-PET after 4 cycles, continued treatment without toxicity. In August of 2017, when I wrote this, he presented to his GP with high glucose, and it was ketoacidotic, requiring an insulin infusion. So he had immune checkpoint inhibitor-induced type 1 diabetes mellitus. It's not regular type 1, it is a distinct entity, but as you'll be seeing, it's more difficult to deal with. He says, very philosophically, look, I'm alive, my cancer's gone away, I don't mind injecting myself 4 times a day, and off he went with his insulin. He didn't restart his immune therapy, and he got back to playing golf, but he faced ongoing issues. Diabetes from this is very brittle, very difficult to control. Only was, when we're talking about wearables just now, it was only really achievable using a wearable sensor which with flash glucose monitoring, and even in Australia that's difficult to access a lot of times. So it's a lot of difficulties, but it did improve his care. He became more frail, and 2 years after ceasing his treatment, he developed a hemianopia and developed a stroke. This was the MRI, as you can see, an occipital issue. He didn't recover from this. His vision never returned. He was unable to read, significantly disabled from this episode. We didn't confirm disease at that point, but then when he was at 91, he became more delirious, and an MRI repeated at that time, which I don't show you, as a solitary brain metastasis. We did do an FDG PET, which showed small volume lymphadenopathy. So at that time, we thought, well, do we give him with more immunotherapy or not? Really, to channel Enrique Soto's work, there was really no hope for recovery of independence in this man. We opted for no treatment and palliative care alone, and he died aged 92 in November of that same year. So immunotherapy in older adults with cancer. What's the rationale for treatment? I'm not going to go through this slide. I just really want to highlight the fact that these are the names of the drugs that we're talking about. And also these are the indications. Certainly in Australia, it's ever-growing indications. There's 3 slides of them now. Skin cancer, which is melanoma, cutaneous squamous cell carcinoma, Merkel cell carcinoma, the non-small cell lung cancer, which of course I'm sure you're all using, in various settings, combination ipi-nivo plus chemotherapy, single-agent development after potentially curative chemoradiotherapy. We're using it in patients with small cell lung cancer now, of course. We're using it in genitourinary cancer in a number of settings, kidney cancer, bladder cancer. Of course, the patients just with MSI high tumours, phase 3 evidence for that. Certainly using that. Esophagogastric cancer recently. Gynae cancers, mesothelioma, as you can see, a long list of indications ever growing. We can see that in FDA applications. This is a paper from 2021 showing the number of FDA approvals for this is growing with or without biomarkers. If we go back in time to the original, using melanoma as the case discussion, we can say it really has been a game changer since then. I'm highlighting this to show some of the data within the trials. These are the trials that introduced us, of course, to waterfall plots and swimmer plots and the important plateaus of the curves, a new way of looking at data. The median age in this studies were not too bad, all things considered. When you look at the age ranges, are relatively high. So this is one of the seminal studies, ipi-nivo versus nivo. So the median age in patients with melanoma wasn't too bad. We also saw that the toxicity list was long, and as we know, it still is. And in this particular case, this the combination ipi-3, nivo-1, more grade 3-4 toxicity as you'd expect in the combination. However, with that toxicity comes improvements in survival, and still ipi-nivo is still, as we've said, the combination is the standard of care in patients with melanoma. In patients with non-small cell lung cancer, of course, this was the other seminal study, Keynote 24, showing that single-agent pembrolizumab improves survival and toxicity in comparison with chemotherapy in patients with a PD-L1 level in the tumour greater than 50%. Now, the median age of this group, less, 64, so that's about 7 years under the median age of certainly patients with lung cancer in Australia. So not surprising, this is a more select group. But despite that, there were still some older patients within it. The 5-year follow-up from this study shows that the survival improvement still is lingering, and from ESMO Virtual Congress, as you all know, from last year. Toxicity, as you also know, is different between chemotherapy and immunotherapy and is generally more favourable, but it is different and not insignificant. Now, what about immunotherapy in older adults with cancer? As we've heard already, is it as effective? What about immunosenescence? Well, essentially the data suggested from a number of sources that it is as effective. There's a Danish population study from patients with metastatic melanoma showing it's effective. And whichever way you look at it, subset analyses, meta-analyses, real-world data, the studies that Ravi as presented earlier, which are not in this talk. So well done for complimentary talking there, Ravi. No evidence of decreased effect. But is the toxicity worse? Another example from my practice, a man with metastatic melanoma, 72, he presented, so he had an FDG PET after commencement of pembrolizumab, showed that he was in remission, but also, as you can see, every joint in his body lit up like, in Australia we say, a Christmas tree. So here he is, he's got widespread, and it's crippling him. He's widespread arthritic changes, generally inflammatory arthritis after only a few doses of pembrolizumab as a single agent. So what he did then was gave him 10 milligrams of prednisolone a day and repeated the PET scan after more treatments because he actually wanted to have more treatment. And we showed that he was still in remission and everything settled down. He got his life back, but he's on prednisolone. So what do we do when we're treating patients with immunotherapy in older adults with immunotherapy? And this, of course, is one of our favourite diagrams from one of Dr. Soto's publications. Strongly recommend it. What happens when we give immunotherapy to an older adult with cancer, given that we can essentially give toxicity to any part of the human body, as you know? And I'd also recommend still this article from many years ago about what the toxicities of immunotherapy are. We know ipilimumab causes toxicity. We know the PD-L1s cause toxicity, what they commonly are, and when they occur. Is it worse in older adults with cancer? Well, it's complex. So here we have a retrospective analysis of patients, once again with melanoma, 254, showing that it's tolerable, as we know. Survival outcomes are the same. But here we have the toxicities, and not insignificant, but not significantly different in many things, apart from maybe arthritis. But then it was better in our older adults. So we know they get toxicity. Is it different? It's tricky. Immunotherapy in this study was given to patients over the age of 80, so age 80 and 90, once again showing it was useful, and there was mild toxicities, and patients who are in the older age group this time had more steroid treatment. As they did in this prospective study from Fabio Gomez recently published, showing that in patients with non-small cell lung cancer and melanoma, single agent immunotherapy, with age distribution between less than 70, over 70, there was no difference in immune-related adverse events, but the exposure to systemic steroids due to the immune-related adverse events was numerically longer, although not significantly longer. In this study, they did a G8 screening tool, so it's starting to see integration of serologic assessment in some way into these studies. A positive G8 screening tool predicted hospital admissions and death. These are the toxicities in Fabio's trial, showing the cumulative toxicities were not significantly different. And where the toxicities were also not different between the two age groups. No surprises, really. G8 was used looking at functional status, and as you can see, predicted for adverse outcomes. Dr. de Glass, in a larger study of patients with melanoma from a Dutch registry, 2,000 patients over the age of 65, showed that treatments are changing. So we can say we're getting slightly more combination therapy as we become more used to using these treatments, and data suggests that it's important to use it in patients with melanoma. And then she looked at other things like toxicity, found that combination treatment was prescribed less, but still prescribed. And age was not a predictor of response to therapy. Excuse me. There was no increase in grade 3 toxicity in older adults. And older patients did receive fewer cycles, possibly due to that lower grade, so the higher grade 1 and 2 toxicity, or should I say, the presence of grade 1 and 2 toxicity in a patient who may be more prone. Recently, we saw Carolyn Presley and Andrew Johns look at 238 patients over the age of 70 with advanced cancer. As you can see there, melanoma, non-small cell lung cancer, etc., with combination or single agent therapy. And they saw that there was improved survival in the younger patients who had more grade 3 toxicity, but not in older patients, as we can see here. So that's about the only times we've seen a differential in improvement survival in age, depending on toxicity. So hypothesis generating retrospective work, but that's what they show. Can we prevent toxicity? Well, Young Seog are leading the way here. They've got a couple of studies looking at immunotherapy in older adults. This first one from non-small cell lung cancer, looking at the phenomena we talked about, doing geriatric assessments to try and see the impact of lower grade toxicities. Once again, Enrico's name is on this one from the patients with melanoma, saying we should do a geriatric assessment, as we all know, as part of the algorithm, and then try to say, well, can we give more frail patients single agent perhaps, or non-frail patients combination possibly. So incorporating this into the algorithm is important. I'll say that the NCCN, however, say that you really shouldn't reduce the dose. As I said earlier, there's a Ipi-Nivo combination where you've got higher dose Ipi-Nivo and lower dose nivolumab in patients with melanoma. They're saying giving a lower dose of that is currently not advised to avoid toxicity because of the we don't know the data on its effect on survival. And what about single agent versus combination melanoma for patients with melanoma? There are a few things that the experts can look at apart from frailty, such as the BRAF mutation type, such as the volume of disease and so on. There are toxicity management algorithms that, of course, are important, and the ESMO article points to that. General principles, of course, you can't just reduce the dose and hope that everything's okay, really. Management does depend on the toxicity, so you'll manage pneumonitis differently from a thyroid dysfunction, but you have to grade the toxicity, use the management algorithm, and sometimes, as I said with my patient, you continue low-dose immunosuppression and continue the immunotherapy. There are guidelines from MASK, which I'm sure many of you know of or are members of. If not, you should be, as well as SIOG. So MASK and the National Association for Supportive Care in Cancer have this publication recently. Once again, algorithms with defined management plans, depending on the grade of the toxicity, for important things like hepatitis, pneumonitis. I'm sure you're all aware of those. And as it comes to older adults, of course, frailty is the key here. This is why you do a geriatric assessment. If you're pushing someone to become dependent because of their frailty, you need to think twice, or support them through their journey, but do the assessment to determine their level of frailty. Just guess. Geriatric assessment prior to treatment, guide supportive care. We don't see an increase in toxicity really with our patients, but our patients may be unable to cope with even the lower grade toxicities because of their age and other comorbidities. They're more vulnerable to side effects of immunosuppression, such as low-dose steroids. Proximal myopathy is an enemy of mine at the moment. What are the role of steroid-sparing agents if they do need long-term steroids? And this is where the rheumatologists are working with us here. They're beating us to our own game. They're saying, oh, hang on, why don't you the paradigm shift for patients with immune-related adverse events? Why don't we use some DMARDs instead? Let's turn the steroids first on the head. So I think we've got lots of studies to do in this space with our rheumatology colleagues. There's some names of drugs which we should be able to know and recognise, not just for their effects on patients with cytokine storms, that's COVID-19. So my final slide is immunotherapy in older adults seems to work. There's no evidence of increased toxicity really, but older adults may be more sensitive to adverse events and side effects of immunosuppression. And as usual, geriatric assessment yields, guides appropriate care and helps us to get the balance right. Thank you.
Thank you, Dr. Steer. That was very comprehensive assessment of immunotherapy for older adults. Are there any questions from the audience?
Yeah. Thank you, sir, for so comprehensive presentation. Sir, I just want to know, in elderly, do we have to monitor these patients more frequently for adverse events as in the normal population, or it should be the same? As we see the less functional reserve and chance of immune toxicity slightly more, as you said.
Yes, well, we should always be doing the geriatric assessment first to try and enhance your supportive care and look for those problems. But yes, more monitoring, it's a question that I guess has not been studied in trials to look for frequency. I must say, however, when I'm giving patients, considering giving them 6 weekly or pembrolizumab or 4 weekly nivolumab, I'm uncomfortable because I started giving this fortnightly and then 3 weekly and then bringing them back down, and I saw problems in the first visit. So if I give someone maybe a 6 weekly due to COVID-19 because you want to get them out of the hospital, for example, I'll do a telehealth consultation or get some blood tests 3 weekly. But that's across the board, to be honest, regardless of age. So should we be looking after our older patients more commonly? Well, if you follow the argument that low-grade toxicity is common and can be more impactful, then you might say yes. But I think that's there's no data behind.
Yeah, so for like this 6 weekly regime, so we should do these hormonal tests, what we do the LH, FSH, ACTH and other thyroid functions before every cycle, or it's the usual parameter which we are following that initially every 3 monthly or so?
We don't really know, but I find blood tests pretty easy to do, and you can get surprises, especially with things like liver function abnormality and kidney ones. They can just creep up on you, and absolutely basic blood tests, thyroid, of course, it's important sometimes, cortisol, etc. But we fit it into a routine, and certainly where we are, it's before every treatment. Sometimes you'll proceed without getting all of the results back, but blood tests are routine monitoring because of the surprises that you can get, such as hepatotoxicity.
Thank you, sir.
I think Dr. Akhil, you had a point to make. Please go ahead.
Yeah, so as pointed out with Christopher sir as well, that further checkpoint inhibitor trials, it is expected and encouraged to incorporate at least some form of geriatric assessment so that we can have some better idea about the toxicities in these patients, because this is actually a data-free zone. We don't have data how these patients are going to behave, and we don't have any mechanism to suggest which one will develop toxicity or which one will not. So I think if we can incorporate at least some form of geriatric assessment, if not the CGA, some form of screening tools, that will help us getting more and more idea. Sir, your comments on the same?
So thank you for that. Yes, so Fabio Gomez's work, which has recently been published, looked at the G8, 8 questions. It's interesting because I do it in my own clinic, and you have to ask the patients things like, what is your self-rated health, and compared with other people, how do you feel, your health status is, and otherwise it's derived from the mini nutritional assessment, which is very diet-based. The teams in America, I know, are using the G8 with an IADL, so the IADLs as well. So there's various ways of doing it, but that's a simple screening one, which, as Fabio has shown, can help predict hospitalisation and death. So there's a simple screening one, if you don't want to continue to the other aspects. But interesting with immunotherapy, as you notice, I didn't talk about a toxicity prediction tool like we have with chemotherapy and Arti Huria's tool. So that, and you can probably see why, it's really hard to predict. The toxicity rate is lower, and it could be anything. So, and I took some slides out from which talk about giving immunotherapy to people with pre-existing autoimmune diseases. We know that that's safe in some, but you're possibly more likely to get your rash if you've got psoriasis. But that's another area of further work. So how do you predict the toxicity? Tricky, ongoing resort. But in general, if you're going to look at the whole person and you're older adult with cancer, then you should do some form of geriatric assessment. The G8 screen is not a bad start, but you can do more.
Thank you.
Thank you, Dr. Sia. I was actually going to ask you about the toxicity risk prediction tool, but I think you answered that just now. So we don't have one, right? For either for targeted agents or for immunotherapy for older adults.
That's right. It's patients over the age of 65 commencing chemotherapy. There's a recent one for patients with breast cancer. which was like a different module, but not immunotherapy or targeted therapy.
Can I ask a question?
Yes,
So about experience in managing the toxicities in a steroid-sparing manner, about use of other the DMARDs or the other immune suppressive agents. So can you share your experience about that?
Yeah, certainly, and I'm sure that you probably have similar experiences where you are, where in the beginning a team approach was thought to be best, where you involve all the other clinicians, endocrinologists, respiratory, gastroenterology, hepatology, rheumatology. As you become better at doing it, picking it up yourself and managing it, knowing what they do, then of course oncologists are becoming more used to doing it themselves. However, there's a few things like the long-term rheumatological conditions and managing methotrexate are difficult. I've got a number of patients on weekly methotrexate or co-managed with the rheumatologist. But the really lethal ones, the pneumonitis and the hepatitis, you usually engage your colleagues with that, especially one or two patients die from pneumonitis. That major challenge, and you run through we don't have access to the DMARDs here. You've got to do a case-by-case assessment for infliximab for your patients with diarrhea, which is a major challenge. Luckily, it doesn't happen all that often. We have certainly moved to using them more quickly if we can, though. But in terms of getting access to the drugs and putting them right up front, apart from just giving a slug of methylprednisolone, we're not there yet. I'm certainly in my patients with hepatitis over bringing forward the steroid-sparing agents. Yeah, we're getting better at it. It's still a team effort for some situations, but funding for medications is an issue even here.
Thank you very much, Dr. Steon. It was a very comprehensive discussion. And I'd like to invite Dr. Vanitha Naruna now to take over the panel discussion. Of course, Dr. Vanitha has been a driving force in geriatric oncology in India, and she's a professor at the Department of Medical Oncology at Tata Memorial Hospital, and also editor-in-chief of the Cancer Research Statistics and Treatment Journal. And Dr. Vanitha, would you please take over the proceedings from here? Thank you very much for having invited me to chair the session. I really enjoyed the stimulating discussion. Thank you very much.
Thank you so much. So, no, it's not projecting. Sorry. Give me a second, some technical issue.
We can see the.
You can see. Okay. So I'd like to start right away. I'll introduce the panelists. Dr. Prem, if each of you could just say hello that you're there. Dr. Prem is a geriatrician in Mumbai. I'm so sorry, I missed you. Hi. Dr. Anant Ramaswamy, he's a medical oncologist and runs the geriatric oncology clinic at Tata. Anant, hi. Dr. Joyita Banerjee is a geriatrician from Delhi. I think she had a family emergency and she had to leave. Are you there, Dr. Joyita? Or maybe not. And Dr. Joyita Devdar is our psychiatrist who takes care of all of our older patients with cancer at Tata Memorial in Mumbai. Dr. Joyita, are you there?
Hello, hi. Good afternoon.
Good afternoon. Ms. Jyoti Krishnamurthy is a gerontologist and our social worker volunteer in our geriatric oncology clinic at Tata. Jyoti, are you there?
Yeah, yes ma'am.
Hi.
Hello everyone.
Hi. Dr. Sridhar Sundaram is a gastroenterologist and in the Department of Nutrition who takes care of our nutritionally vulnerable older patients with cancer. Dr. Sridhar, are you there?
Hi. Hi.
Dr. Sarika Mahajan is our physiotherapist, a very active physiotherapist, and there's an entire assessment of all of our patients and a follow-up. Dr. Sarika?
Hi ma'am.
I'm here. Hi. And Dr. Vikram Gota, our clinical pharmacologist and one of the most avid supporters of our geriatric oncology clinic, and he sends his students, and some of them are here. So, Dr. Vikram, are you there? You're here in person, sorry. Hi. The last three need no introduction. We have already heard the excellent talk. So Dr. Kaneswaran from Singapore, Dr. Soto from Mexico, and Dr. Steer from Australia. So let's start right away. So this is a real patient that we saw in our geriatric oncology clinic, and several of these issues I really don't know how to solve. So let's start. So she's a 77-year-old woman, lives in Mumbai. She's a widow, but lives at home with family. There are 3 people who live with her at home. She comes to our clinic with her granddaughter, who is one of her primary caregivers. So we were lucky. This is a person from Mumbai. Oftentimes, a large proportion of our patients come from outside Mumbai, and they are not accompanied by their primary caregiver. But in this case, she was. She is illiterate. She was a housewife. She is well preserved. She had an ECOG of 1 and exercise tolerance of 2 floors. Never smoker, no addictions, no family history. She had a history of cecal cancer 3 years ago in August 2018, underwent a right hemicolectomy and 8 cycles of adjuvant capecitabine completed in December 2018. She has some comorbidities. She's hypertensive. She has diabetes for the last 10 years. She's on hydrochlorothiazide, glimepiride, and aspirin. She's also taking a multivitamin, calcium, and vitamin D, and has recently been started 3 weeks ago on tramadol for pain and pantoprazole. So as an aside, when she presented to Tata Hospital, we didn't see her. So this was the case history that I took from our electronic medical records. So she presented to the thoracic disease management group with a 3-week history of chest pain, cough, vomiting, and diarrhea. She was noted to have localized a lung mass, so a 3.5 centimeter right midlobe lung mass, and some few mediastinal nodes, but they didn't really uptake on the PET. So there was a concern, there was a discussion in the multidisciplinary team, and we thought that they were not involved nodes, so just a lung mass. And there was some uptake in the left iliac fossa in the cecum, which she underwent a colonoscopy, and that was not disease. So ultimately, she was diagnosed with localized lung cancer. She was discussed in the multidisciplinary tumor board. She was noted at that point to have a very good general condition. Her ECOG was 1, exercise tolerance was 2 floors, a 6-minute walk test was good. Her renal function was a bit elevated at 1.3 milligrams creatinine. And so she was felt to be fit. At that point, she underwent an upfront VATS lobectomy and selective mediastinal lymph node dissection. So questions for the panelists. So this patient was not referred to us prior to her surgery. Did she require a geriatric assessment prior to surgery? And in your setups, are patients being seen? So I think this feeds back to Dr. Sapna's question as well. So in radiation oncology and surgical oncology, are patients being referred for geriatric assessments? Do they benefit? I'll ask Dr. Kaneswaran first and then the other panelists.
Thank you, Vanita. And really interesting case, a survivor of colon cancer, and then now with this new lesion. To answer your first question, does this patient require a geriatric assessment? The answer is yes. Prior to surgery, definitely the patient will benefit from a geriatric assessment. Now, the second part of your question was, is that routinely done globally? And that is variable. I think many surgeons, they may not call it geriatric assessment, but have prehabilitation programs. This means they actually work with their rehab medicine specialists, physiotherapists and all to assess these patients and start on some kind of preparation for the surgery in terms of physical therapy to get them fit enough. And obviously outcomes from this process will be a lot better in terms of recovery, in terms of hospital stay, shorter durations, things like that. So that's my answer to both your questions. In my practice, the surgeons don't necessarily do a geriatric assessment, but they do have such prehab programs in both hospitals here.
Dr. Soto, in your setup?
Yeah. In our setting, these patients will have probably be seen by what we do is that all patients age 65 and older now at our hospital are with a new diagnosis of cancer, at least undergo a GA, NetCPV or Time Up and Go and a Minico. And we train the oncology fellows and also some of the surgeons in doing this. And the urologists also do this. And when they find any abnormality in this screening test, patients get referred. So I believe that this patient will have probably be seen by us. I think that this is feasible and something that we should try to do in low and middle income countries and in a resource limited setting, training surgical oncologists and medical oncologists in at least doing screening tests for patients. I think it's very feasible, can be done everywhere.
Perfect. Dr. Steer. So, and I think a follow-up question to that for you, Dr. Steer, and then Dr. Anant and Dr. Prem. So, if we did a geriatric assessment prior to surgery, presumably the patient is scheduled for surgery within a few weeks. So, and we think that the geriatric assessment is, by intervening, you will improve outcomes. So, do you really have sufficient time to improve outcomes, and do we have any data that it benefits in the surgical setting?
So this is thoracic surgery, is it not? From
Yes.
memory?
Yes.
Yes. So interesting here. Our thoracic surgeons are 300 kilometres away. We are a regional centre, and we don't have that service. So, but we interact with them as part of a multidisciplinary team, as if they were in the next room, like I'm could be in Mumbai at the moment. So we have, and that's something the COVID pandemic has done. It's helped bring teams together. So our patient would be assessed for in a major capital city. We don't have the ability to capture the patients prior to surgery here in our local centre, but they get a rigorous assessment prior at the bit larger hospitals in Melbourne. And of course, the cognitive assessment for me is the one here. I don't want to find out that this patient has a delirium risk at the time of the operation or afterwards. You want to know that prior, so that would be the one that I'd be more interested in, quite apart from her physical assessments and ability to cope with the rigors of the operation.
Perfect. Anant and then Prem.
So I think this patient would require a geriatric assessment. One thing is that a lot of the pre-anesthetic checkups that are done for older patients are actually quite extensive, and that takes care of a lot of things. They do a 6-minute walk test, they do pulmonary function tests, they do, look at physio. So a lot of it, even if it's not technically called a geriatric assessment, I think a lot of geriatric issues are taken care of, in the PAC. So, I think, and all these things would help. I don't know the time duration for these interventions to actually help the patient. Is it 2 weeks, 4 weeks, 6 weeks? Maybe someone else could throw light on that. And we know that majority of our patients, you would know that well also, Dr. Vanitha, that the surgeons don't refer as many prior to a surgery, but the PAC takes care of a lot of things.
Prem, to you. So, are you seeing, Dr. Prem is a geriatrician practicing in a private hospital in Mumbai. So, are patients referred to you prior to surgery?
I think what Dr. Anand said, most of the times it is usually the PAC, which is obviously very standard that they do. But I think the PAC does not cover a lot of things. It covers more what the surgeon wants, to be very frank, and not necessarily what an older person who is having a surgery would want. So, for example, I had my own patient who had a thymoma. It was a thymic carcinoma. So, and the surgery went up. So I myself, because I was a geriatrician, so I did all the CGA and I sort of had it ready. Because I wanted to know what the outcomes would be. And I totally agree with Dr. Steer. I think delirium is something which is very standard, and sometimes depending on the duration of surgery, whether it's acute or whether it's sort of a planned one, we tend to sort of neglect it purely because the focus is more on the surgical outcomes rather than the fact that the person can easily go into delirium. I have seen patients going into delirium after going into an MRI machine as well. an older adult. So another part, of course, for very important in the assessment part, I think, is knowing the cognitive part in what level. For example, is it Is it minimal cognitive impairment? Is it MCI? Is it even pertaining towards maybe even worse dementia? I mean, the reason I'm saying it should not always be the call that because the person has an advanced dementia, we should not do the surgery. But at the same time, sometimes if the comorbidities and everything is taken into consideration, then we might have to take an overall call when to do it. And as far as the weeks, I mean, the duration before, I would say at least once. See, this is where, if you remember, in case of palliation, palliative care doesn't start later. So at the same time, I would say that as soon as the diagnosis is obviously over and the decision has been clinically taken, the geriatrician or the geriatric assessment should be done baseline, and then even before surgery, just to know if something has sort of changed, which might make a major difference depending upon when the surgery is. Post-surgical, because surgery is done, but if the outcomes are not as expected, as far as a geriatrician for me is concerned, which includes quality of life, which includes whether the person will go into delirium, what is the physical ability that the person is going to have after the surgery. So these things, I think, matter a lot. And I think better sensitization and education is something, even for, I mean, as we said, medical oncologists to a great extent have really sort of world over adapted that geriatric assessment is sort of really needed. But it needs to extend to the radiation, therapists, radiation oncology as well as surgical oncology. And purely, I think, in the level of tumor boards, which actually happens very commonly. I think at that particular time, if a geriatrician is involved or the assessment is already mentioned, then we are able to know the planning might actually go better. So I think that is the best way to go for.
No, I totally agree. I think our tumor boards, you barely maybe take a few minutes per patient, and I think the bottom line is that they have to be referred prior to for that. I'd like to keep this open and interactive. So if anyone has any questions, please ask at any point, and even if you don't, please ask. So moving on. So it seems to be stuck. Okay, sorry. So the patient underwent a lobectomy and a mediastinal lymph node dissection. Post-operative course was uneventful. She was discharged on post-operative day 4. Her histopathology showed a 3.3 centimeter adenocarcinoma. Margins were negative, but 4 mediastinal lymph nodes were positive. She was then referred to our medical oncology clinic for consideration of adjuvant therapy because she had a T2N2 lesion. So the first step was the medical oncology opinion. So the impression was an elderly lady with a history of CA colon, now with a second primary adenocarcinoma of the lung, P-T2N2M0, but creatinine of 1.6. Her hemoglobin, now this is the post-operative setting, so it was 7.9. She subsequently got a transfusion. Her echo was normal. So the initial impression and plan was tentatively planned for adjuvant pemetrexed and cisplatin, followed by consideration for adjuvant radiotherapy. But consider a geriatric assessment. So she then came to see us in the geriatric oncology clinic. So couple of questions before we go to her full geriatric assessment. Now this is a patient who is quite old, and at the point that she was seen in the clinic, she was considered frail. But my question is this, and again, this does not happen for all patients. Many patients, a decision is made without a full geriatric assessment. So I think this was covered in some of the talks, but if one of you could just summarize. So if a full geriatric assessment is not possible, what minimum assessment should be done other than a G8 screening test? Dr. Kaneswaran?
That's a good question, Vanita, and I think I alluded to this earlier as well. For a start, a screening like a G8, as you mentioned, does play a role, although while saying that it adds a little information but doesn't really give you the full picture. So if really time is of essence and it's very hard to get a full assessment, other tools like the CARC toxicity, chemotoxicity score, especially if you're planning chemotherapy for these patients, is useful as well because it gives you an idea of what kind of toxicities the patient may experience, the grade 3 to 5 risk, and that can help you with regards to planning doses and also counseling patient with what kind of like toxic side effects they can expect. So I think these things are useful, but may not replace what a geriatric assessment may provide in terms of the depth of knowledge that can help you plan. But I fully understand, even in my practice, it's very, very challenging to do a full geriatric assessment for everyone. So you have to make do with what you can do and is practical for use in your own setup.
Perfect. And I think I'll ask Enrique to summarize, because Enrique practices is perhaps the most similar setting to us in Mumbai. So in your setup, Enrique, G8 CARG ideal? What is the bare minimum that is done?
So our setting, the bare minimum is doing a G8, a mini curve, and some functional tests like time up and go. However, I do believe that even in limited resource settings, doing a geriatric assessment that contains more of the things that the ASCO guidelines recommend is feasible. So at least assessing IADLs, a quick screening for depression. I mean, you can use PHQ-2, which is 2 questions, weight loss, very easy to do, assess or ask about falls. We've even developed a short self-administered geriatric assessment in Spanish that takes 15 minutes for the patients to complete on their own. So I do believe that the core things that ASCO guidelines recommend should be done in patients like this that are starting a new treatment, a long treatment, a complex treatment. So I think that for these patients in particular, there are ways to do a more complete geriatric assessment, and I wouldn't be happy just doing screening for a patient that's gonna undergo adjuvant chemotherapy and perhaps radiation for lung cancer. And again, we have to get rid of the idea that doing a more complete geriatric assessment is very time consuming. We can actually look at the important issues without taking a long time.
I have a question here, Dr. Vanitha, if I may.
Please go ahead.
Yeah. So while I was looking through all the instruments that we were going to, possibly use in our setup, I came across this numerical multi-dimensional prognostic indicator. And I just wondered if somebody had any experience of using, because it seemed to really be very thorough and, give a numerical value to everything. So I just wondered if there was any experience of using that.
What tool is that?
Well, the multi-dimensional prognostic indicator, I think it comes from some Italian groups, and there seems to have been some work in Europe on using that tool to, do decision making.
I think it's something similar to the OncoMPI. So it's essentially, if I'm not mistaken, it is a complete geriatric assessment, but with points that have been given to each vulnerability and each domain. Is that correct, Dr. Sapna?
Yes, very right. So this is, I think this predates the OncoMPI and just is MPI. And so I just wondered, have you all, has anyone used this? And OncoMPI too? Do you use that, or is it just G8 and the other one, the chemotherapy? Because the chemotherapy tool is, doesn't really help, for example, a radiation oncologist or a surgeon.
So I'll ask Anant to talk about that. We were, I agree, we were also quite excited because, this, the geriatric assessment is so subjective, and we really, at least, have not really been able to come up with a very objective way to decide what to do per patient. So the idea of having a numeric scale and, giving a number and whatever the number is, you decide based on that was quite attractive to us. So Anant had done some work looking at our data. So Anant, you want to discuss that?
I think what Madam Dr. Sapna is referring to was the initial 2011 when, the MPI came about, and then I think the Italians came up with an OncoMPI in 2016. I think that's the chronology. The thing is, it's not an easy equation to apply. I mean, this is when we were analyzing our own patients, we decided that we'll analyze a little later because some of our patients had a shorter follow-up. It's actually a very long logarithmic equation, you know. So, but that said, if you had an OncoMPI calculator, it predicts very well. It clearly differentiated. I think they had cutoffs of 0.45, 0.65, things like that. And those who had a score of 0.45, there was difference in terms of survival in years, not just months or something. You know, so on paper it looks great, but you need to have that calculator. You cannot manually enter those values because that would take, you know, a long time in itself. We tried to validate it, but we now decided to wait a little longer for follow-up because the follow-up in our patients was much lower. They had a good follow-up of more than a year. So maybe we'll have something in the Indian setup maybe in 6 months' time or so. But it's a long equation. I mean, I think you should see the equation to know how long it is.
So maybe I can add something here. But here, you know, with OncoMPI, it's a prognostic tool. Am I right? It gives you prognosis. So, I mean, a decade ago, we did something similar and published it at about the same time as when CARG and CRASH was coming out as well. It was a nomogram and it was a prognostic tool as well. And it used, and we used, at the end after our, analysis, we found that there were 6 factors from the GA that were relevant. And then on the nomogram, you can plot and see what their 1, 2, and 3 year mortality is going to be. Now, the challenges with all these prognostic tools, just like e-prognosis, is that it doesn't really tell you what you should do with your patient. You know, how should you treat your patient? Should you dose reduce? It tells you what to tell the patient about their prognosis based on multi-parametric assessments. So, like Christopher had mentioned in the chat box as well, e-prognosis was developed mainly in Caucasian populations. So, whatever information you are going to get from your studies in India and in Asia would be useful to see whether there are differences in our own populations, and I suspect there will be. So I think for tools like this, if it's not been validated in an Asian or local setting, then I would say be cautious when using them. And again, you need to also think about applicability, because even with CARG, firstly, it doesn't. I mean, there were multiple tumors in there. There are limitations to the usage of CARG. How would you counsel a patient when the CARG score comes out as 50%? What are you going to tell the patient? It's 50% risk of getting grade 3 to 5 toxicity. But how does that translate to what is going to happen to me? So that's what the patient will want to ask you. So you need to have answers to all those things, you see. So whenever you come up, you want to use any of these tools, you have to take it in the perspective of what is the next step and have a plan for that as well that's useful and relevant to the patient. Otherwise, you'll be stuck.
I totally agree. So, moving on, so the patient came to our clinic, and these are the results of the geriatric assessment. So, before we go through all of these results, Dr. Steer and then Dr. Prem, is it valid to be doing a geriatric assessment in the post-operative setting, and how do you interpret those results?
Thanks for the question. Just to continue on the previous ones, I'm approaching this as a medical oncologist with the patient coming to me in whatever time, and I'm going to want to know how can I enhance their supportive care with a cancer in the older adult lens, and I need to know more about them. The screening tool that we use is the G8, and then Armin Sharokni's ERFA, 15 minutes. You do the tug and the mini-cog. And then that's so we don't have a geriatrician to lean on constantly. And so I'm a medical oncologist. I've got resource limitations. We've got an electronic thing. And I want to know that as early as I can. But of course, they need to be stable. So they can't be unstable after the post-op period, clearly. But if they're stable and considering adjuvant treatment, I want to know their prognosis without the cancer, hence my question about the prognosis. And then this is a framework to build the supportive care that's needed to get them through adjuvant treatment, significant adjuvant treatment, if their survival is good enough and they agree. That would be my approach.
Perfect. Dr. Prem? So I guess my question is, do you adjust what you find in the geriatric assessment after an acute event? So sometimes a patient falls the previous day and comes to us and you can't assess function, and we'll talk about that in a little bit. But do you have to put some sort of an adjustment to it?
Actually, for example, if somebody has had an acute event in which there is a significant depression of function, we know that the baseline has gone down. But if you're saying that we do the entire thing there, then we might not get the results that we actually want. For example, a very simple way: if somebody has fallen and the person is in pain, for an older adult, pain can induce delirium, pain can induce results for whatever we ask, and maybe it's a lack of interest, or maybe it's just they don't want to answer. So that can be a big sort of back as far as the results of the geriatric assessment are concerned. So we would not get what might be the actual sort of result. So I think we might have to set. I wouldn't say that there is a fixed amount of time in which we should wait, but all I can say is, if we feel that with basic thing, for example, if the mental status that we feel is okay, which could be purely GCS, or we ask leading questions for the memory and of course for pain, and then we will be able to know at least the answers that we are getting, they are right or not. That is one. And another thing, because Dr. Joeta is not with us, there is of course her screening tool, which she would have talked more about.
Scope-C.
Scope-C, that is screening for older cancer, screening of older cancer patients. So that is basically, I myself have sort of done it for patients as well. So it doesn't take a lot of time, but again, it sort of needs validation, which we obviously know, because multiple centers in India need to do it, and then we need to it has been done in AIIMS in New Delhi. So I think that is also another scale which we should look at least in the Indian setting, because it has been done in India, and maybe that is something which we sort of can, sort of apply to various centers and get some data and know where exactly it sort of helps us in better treatment as far as older adults are concerned with cancer.
Perfect, thanks. So we'll go through each of these relatively quickly. I think we are almost out of time, but in terms of assessment of function and falls, Dr. Sarika, can you comment? And any tips for us how we can implement that in the clinic?
So ma'am, if we are looking at the patient's history, the ECOG score is 2 and patient already has a history of fall once. So we need to go ahead and do detailed assessments for balance and also for strength. So we usually use the SPPV model, which is very, very safe and most of the patients can perform. And if you look at the TUG score also, it's more than 12. So for such patients, what we need to do is, we need to do an individualized intervention. So like we were discussing before, as to how much time is enough for interventions from physical therapy point of view. So there are many papers which quote saying that, you can go at least for minimum of 2 weeks of interventions, working on the strength, balance, and improving the aerobic capacity. So I think if we can work on these domains for at least 2 weeks, the patient can sustain for the next 6 months to a year and cope up with the treatment which she's will be going.
Perfect. Thanks, Sarika. And I think that's an important point. We try to send all our patients to you. Now, this is the actual geriatric assessment. So you notice that there's no SPPB as part of this, because this patient didn't actually reach you, Sarika. So I'll ask Jyoti to comment on this. So how much of difficulty do you find in terms of patients following through with what we recommend, and as well as in terms of filling out the patient-related forms? And tips for us for that.
It's like when the patient comes, the patient is always in a hurry to to get his chemotherapy or radiation. So it's explaining the importance of having the geriatric assessment is like the first point of contact for me. And it's most often the caregiver who comes. So explaining the importance is that's what I start with, and then when the assessment is done, the referrals for psychotherapy or for physiotherapy. So again, I have to, because generally the patient has to go to so many places and they are in the mode of can I just skip this? So I kind of if you want to remain active, and the importance of the exercise. That is what I tell them, and then later on I keep following with them, like, after 2 days or so, because if you keep calling them, the probability of them going and visiting Sarika ma'am is that's higher.
Thank you, Jyoti. No, the real world problems, I guess. I don't know, in other setups, do you have a sense as to whether patients are actually following through on interventions and recommendations, I guess, rather than interventions? Enrique, Dr. Steer, Ravi?
Actually, in Singapore, the issue is also cost. Because with every intervention, the patient has to pay an additional cost, and there's convenience factor because they need if it's not housed under one roof within the same setup, they need to go to another center for physiotherapy and another clinic somewhere else. And even if it's within the same campus, all these distances for an older adult can be challenging. So what I find is ideally, and we are moving to a new cancer center with more space, I may be able to overcome some of these issues by making it a one-stop shop. That means either within the same floor and also have to try to find a way to bundle the cost. Because, ultimately, if you are not getting support from philanthropy or the government, patients have to pay for the nutritional advice, the physiotherapy, the occupational therapy, any form of additional support, seeing a geriatrician, all this is going to cost money. And for many patients in Asia, where a lot of it's out of pocket, they'll think twice, unless, even if you convince them it's essential. So that's why you need to build some form of multidisciplinary team and bundle these packages such that you can bring down cost and make it worth the patient's time and effort to get these things. I feel those are the big hurdles that I'm facing as well.
Perfect, and I think similar here. Enrique or Dr. Steer, anything to add to that?
No, I agree with Ravi. There is a need to integrate this into a single visit. We've managed to have a nutritionist and a physiotherapist at the same geriatric oncology clinic, and that helps us implement some interventions. And I think another very important thing is to adapt our schedule to the patient. So many of the patients will be coming to the cancer center a lot for chemotherapy, radiotherapy, etc. So there are a lot of opportunities for implementing interventions in these idle times patients have. So while patients are waiting for chemotherapy, or even while they're getting their chemotherapy, there are opportunities for educational interventions, etc. So I think that those are things that could be optimized to provide this care. We've had good results at follow-up and the acceptance of regarding interventions, as long as they see it as part of their usual care. So I do think that we need to integrate this. This is part of your cancer care. It's not an extra thing. It's part of the team.
That's right, Enrique, and I think you should get the award for the, it's 1:15 in the morning in Mexico City, so welcome to my world, but you've done superbly well. And yes, as someone who I have the privilege of sitting on the CARG clinical implementation group where we hear the experiences of people who are trying to integrate geriatric assessment and services into their cancer centres around the United States, England, the Royal Marsden is doing a fantastic job at the moment, Australia. And everyone has similar problems, but with those problems come opportunities. And so you use the things that you've got. I know you're doing superbly well in your centres. Use your teams, do what you can, and try and get if I can do it on a supportive care lens like we're doing here, you get the information early and support the patient through their journey. And that's what I'm learning. Use your what you've got wisely with the patient at the centre, and you can't go wrong. And look, you're doing it amazingly, Tara Namunga. This is a fantastic event, and I really appreciate the opportunity to be part of it. Thank you.
Thank you so much. Sridhar, your comments on nutrition assessment. So this patient was actually okay nutritionally, but her MNA was 24, so still vulnerable. So she's in the post-op setting. She's not really eating 3 meals a day. Your comments on sarcopenia or nutrition? Or
Yeah, so thank you, ma'am. So, of course, we are also using the MNA in routinely in clinical practice. Now, there are some modifications of the MNA. Sometimes you cannot go by the BMI for a lot of patients, especially these older patients who might have a high BMI but will be frail. So, a frailty assessment and some modifications of the MNA, like the proportional MNA, may be of use in these settings. So a formal frailty assessment is something that I guess we miss out on commonly in these older individuals, and so I guess that also has become part of an assessment at our nutrition clinic now. I think there was discussion on, because of the pandemic, a lot of patients starting to use telemedicine. So for nutritional assessment, again, recently there have been papers on self MNA. So off late, even for phone, for teleconsults, we started using some self MNA. So again, that has come in and that's already validated. So it's been of good use for the nutrition clinic, and at least it gives us some sense of assessment as to how the patient is nutritionally. So overall, I think it should be a combination of both an objective scale like the MNA and some frailty assessment when the patient actually comes to the clinic. Another issue becomes these patients, their intakes are low, especially the ones who are extremely, low BMI. They have a very high risk of refeeding once you start, nutritionally rehabilitating them. So again, that becomes a major concern. Of course, not in this patient. She seems otherwise okay, but in those patients who are really low BMI, that becomes a concern. So all of these are, common issues that we face in the clinic.
Perfect. In the interest of time, I'll just take just one more on for Vikram. So your comments on the medications, and I have to admit that she actually was not on all of these medicines, so I added a couple of them because these are the ones that we see are most commonly prescribed to almost all of our patients. So just your comments, Vikram, on polypharmacy and these medications that the patient is taking.
Okay, as you see, the prescription has all the bad boys of polypharmacy of geriatric oncology. So if we have to go one after the other. So hydrochlorothiazide, there are a lot of good studies in the past which have shown that hydrochlorothiazide is very effective in preventing cardiovascular events, especially in elderly patients with mild hypertension. So, but once again, the effectiveness is only at lower doses, and then the higher doses are likely to have complications. So, predominantly dyslipidemia, gout, and so on. So, in this case, a patient with already creatinine of 1.6, I don't know if I want to risk treating with hydrochlorothiazide. Perhaps if I have to, I'll stick with a low dose. Otherwise, there are definitely comparable drugs with comparable activity, but lesser toxicities. Maybe ACE inhibitors or ARB may be a good substitute, or even a calcium channel blocker. So that's how I would look at it. But if it is mild hypertension, hydrochlorothiazide is not a bad drug, but definitely we can consider alternatives. When it comes to glimepiride, in the sense, some of these long-acting sulfonylureas, one should be very, very careful in older patients because the risk of hypoglycemia and then the subsequent complications, maybe chances of fall, because the patient already has had a history of fall once in the last 6 months. So definitely glimepiride is a no-no in this case. A better alternative would be gliclazide because it is short-acting. It has a lower propensity to cause hypoglycemias. So maybe, I would want to consider, replacing glimepiride with gliclazide. Then tramadol. Tramadol, once again, in very old patients, beyond 75 years, especially with impaired renal function, because her creat is 1.6, so her creatinine clearance is likely to be in the early 30s or 40s. So once again, the elimination of tramadol will be affected. So they're likely to have more complications of the tramadol, like constipation for that matter. or even SIADH is more likely at this age. And long-term tramadol treatment can cause problems like seizures and Alzheimer's and so on. So, yeah, I mean, once again, in older patients, it has been shown that a low-dose tramadol is what we should start with if you have to. So, a patient more beyond 75 years, I would start with a dose of 25 milligrams and then see how it goes, how the pain control is. And first of all, an assessment should include whether she will require tramadol at all, or we can manage with acetaminophen, because that is as good for mild to moderate pain. But if tramadol is absolutely indicated, then I would start with 25 milligrams and escalate from there on, but definitely not more than 300 milligrams a day.
Perfect, thank you. And lastly, the psychological status, Dr. Joyita Devdar, your comments on, if they do have depression or insomnia, your tips for us, and how do we help these patients through? And she has somewhat of a borderline cognition. So if we did plan her for chemotherapy, anything that we could do to help?
Thank you, Dr. Vanita. So I think the cognition, it is still sort of mild, and then she's had a history of surgery already, so I wouldn't really worry so much. I will do a cognitive testing as part of my mental state assessment. It's important if the thing that is going to be making more significance is whether there has been a change. So if there has been a change from her pre-morbid functioning to now, I need to take care of that. For her, the other scales that you have used, so as part of that cognitive testing, we should talk about her decision-making capacity, and that is why the corroborative history from the accompanying person is really important, and somebody who knows the lady, not as somebody who is just accompanied on that day. That's an important consideration. For the GDS and the GAD, there doesn't seem to be anxiety screening as such on the screening, but the GDS is 5, which is mild. But for our assessment, these are screening tools. We would do our own assessment and do a thorough mental status examination, which would give us a diagnostic formulation. For tips, it's important to have that they really like to share their experiences and talk, and a lot of it, what they have gone through is medical. So that bit has been, during the part of the assessment, that kind of sort of informal discussion and sharing does help a lot, and we should always think about that loneliness and the isolation bit, and that we need to do that. We were talking a lot about follow-ups and whether they follow up when the appointments are made through, but because the appointments are made through well in advance and they have a specific time for that, we haven't had any difficulties in them attending our appointments. And for follow-up, I understand it's difficult again for them to come because they have so many things. We usually tell the family to please come and report to us either way, or else if they have been started on any antidepressants or any other medications.
Perfect, thank you. I think in the interest of time, I'll end. I had so many questions about how to decide her treatment, but we'll leave that for the next because I don't want to overstay our time. So I just wanted to acknowledge everybody on this slide has really helped me because we actually I have no formal training in geriatric oncology, and I was totally lost when I decided to start out. So I reached out to each of these, and I have realized that the geriatric oncology community is really such a helpful and a collegial community. So whatever question I've asked has always been answered. So thank you. This was the lecture given by Professor Andrew Chapman, and when he had received the ASCO Award for Geriatric Oncology, and he had said that geriatric oncology is a team sport. So it totally is a team sport. So thank you to all the members of our geriatric oncology clinic at Tata. It's growing. It started as 2 people, and it's now I don't know, 15 or 20 people and growing. So thank you all very much. Akhil, the stage is yours for the quiz. I have one last question. Yes, please. Please, go ahead.
Dr. Sundaram was mentioning about frailty. So it's assumed that most of the people, when they grow old, they become frail. And I just wanted to know if anyone could share some light on the use of Edmonton Frailty Scale, like how, if anyone has ever used that for assessment of frailty in older patients.
Dr. Steer or Enrique, Dr. Soto, would you like to take that? So I'll tell you from our experience in the clinic, so we are using the Rockwood frailty scale, which is scored by the physician. And I have realized that we are always very optimistic in terms of what we rate the patient, because I see that it goes from 0 to maybe I think 10 or 12, and 1, 2, 3 is very fit, and 12, the higher numbers are very frail, and invariably the patient is scored as frailty 3 or 2, and then I look at the ADL and the patient is not even able to do 3 ADLs. So I think, this is not possible. So I'm not really sure about the how valid it is, at least not in our setup, until we realize, we explore more with the patient. Comments from Dr. Soto, Dr. Steer, Dr. Kaneswaran, or Anant? Or?
Yeah, well, I think that the concept of frailty from the geriatric standpoint and the oncologic standpoint is not exactly the same. I think that some of the frailty definitions used in geriatric, like the Rockwood scale, or even the frailty phenotype, are not necessarily validated in cancer. So even though this may make sense from a geriatric standpoint, it's not the same as the geriatric oncology frailty concept, no? Which is not exactly the same as that used in geriatric. So for some of the definitions of frailty in geriatric oncology, like the Balducci scale or other things by SIOP, are a little bit different. So there is no clear use of the frailty phenotype for cancer specifically. The Edmonton Frailty Scale is very nice because it encompasses a lot of things that we normally do in the geriatric assessment, like IADL, continence, etc. It's more of a definition of frailty based on the accumulation of deficits than on an actual phenotype. So I think that the definition of accumulation of deficits is much more compatible with what we usually do in geriatric oncology, rather than the phenotypical definition. I don't know what Christopher thinks.
It's a complex issue. Whilst medical oncologists and others like numbers, I think geriatric assessment is a way of personalising care in a way that my colleagues want to do next generation sequencing on the tumour. It's personalising in one way, but it's not the same as actually doing an adequate assessment and guiding your care of the patient, individualising that. And you can do frailty numbers to maybe help in decision making. I haven't seen any evidence that helps yet. There are many scales. And the other answer to that always is, well, if you feel useful using one, just pick one, because there certainly isn't any differences between them, and the Edmonton score may be helpful. But whatever you find comfortable, whatever your geriatricians are used to using, with the caveat that Enrique says that there is a difference between older adults with and without cancer. I don't use a frailty scale, in preference to the simple assessment.
Perfect, thank you. I think we'll hand over to Akhil, because we are running a bit late.
Thank you, ma'am. So now we will be conducting a short quiz. It will be a 5 questions based multiple choice questions, best of 4. And there are some questions which are based on the basics of geriatric oncology and 2 on the important recent trials. So technical team, please project the slides. There will be 30 seconds for each question actually. So, starting with the first question, which of the following is not correct about the G8 screening tool? Score lies between 0 to 70. Higher score, better health status. Score more than 15 should undergo CGA. Includes age, food intake, weight loss, mobility, BMI, and neuropsychological problems. So, quiz is for the students, not for the consultants. Please don't give answers on the chat box. I think the time should be up. Yeah, time is up now. Let's move to the second question. Which of the following is false about the CARG tool? This was discussed today significantly. This tool is based on data of 500 older patients receiving chemotherapy, and it was worked by Huria et al. Poly versus monochemotherapy is included as a part of the risk assessment tool. Type of cancer is also a part of the tool. Administration time is around 20 minutes. So it is about false about the tool. You need to select the best answer out of the 4. So time is up. Let's move to the next question. So which is true about CRG versus CRASH tool? So these are the two basic tools used for assessment of chemotherapy toxicities. CRG tool is validated for patients over age 70 plus. CRASH tool's administration time is shorter. CRASH tool is validated for patients aged 65 or more. CRASH includes IADL, MMSE, MNA. So which is the following is true? Only one out of these is true. Select this. Okay, let's move to the question 4. So which is of the following is not correct about the GO2 trial? So this was a recent trial, and this is very important for us now. It was a phase 3 trial in older patients with gastroesophageal cancer. 3 dose level of Capox were used, 80, 100, 80 and 60% doses. Both PFS and OS were found to be similar in all the 3 dose levels. Reduced doses did not lead to any difference in the quality of life. Which of the following is not correct about the same? Select the best answer.
Advanced.
So let's move now to the final question. Which of the following is correct about the GAP 70 plus study? This was also discussed today. Geriatric assessment led to improved survival in patients with age of 70 plus years. Grade 1 to 2 toxicities were significantly reduced by following geriatric assessment. Grade 3 to 5 toxicities were significantly reduced by using geriatric assessment. Significantly higher number of patients in geriatric assessment group were offered more aggressive chemotherapy. So you need to select the correct out of the 4. So time is up. The results will be announced separately, and the top 3, those who come in the top 3 will be given free registration to the next ESMO Asia conference. That was announced by Vanita ma'am. Thank you. We can stop now. Back to ma'am for final comments and closing session.
Sorry, so we are, thank you Akhil, and I think we had forgotten to announce, so the prizes for the quiz, so the top 3 will get free registration for ESMO Asia 2022. So we should have announced this before, so more people participated, but Either way. So thank you so much. This was really, it's always an eye opener to me to hear what other people think and how people practice. So thank you so much. I hope that all of us can go back and at least assess a few more patients appropriately in our clinic. So thank you. Thank you all.
Thank you, ma'am.